Sanjeevani College of Medical Science, Dr. Nitesh Kumar Kanodia sir. Medical Superintendent of Bheri Hospital, Dr. Nirajan Subedi. Medical Superintendent of Sanjeevani College of Medical Science, Dr. Roman Kidwai. Hospital Director of Nepalganj Medical College, Dr. Resam Rana. Colonel Dr. Sagar Mani Jha. Dr. Subhash Pandey. Bardia ko Medical Superintendent. SSP Dr. Deepa Nuche Pradhan. Finance Chief of Nepalganj Medical College and Sanjeevani College of Medical Science, Dr. Dilli Bhusal sir. लाई आफ्नो आसन ग्रहण गर्न विनम्र अनुरोध गर्दछु। त्यसैगरी यहाँ उपस्थित हुनुभएका सम्पूर्ण स्वास्थ्य संस्थामा आबद्ध र स्वास्थ्यसँग सम्बन्धित सम्पूर्ण सरोकारवालाहरू, उपस्थित पत्रकार महोदय र हाम्रो यस कार्यक्रमको निमन्त्रणा स्वीकार गरी आइदिनु भएको सम्पूर्ण महानुभावहरूलाई आफ्नो स्थानमा आसन ग्रहण गरिदिनु हार्दिक अनुरोध गर्दछु।
त्यसैगरी हाम्रो एलबीए का प्रमोटर डाक्टर केदार अग्रवाललाई पनि आसन ग्रहण गरिदिन हार्दिक अनुरोध गर्दछु। अब यस कार्यक्रमलाई अगाडि बढाउँदै यहाँ उपस्थित सम्पूर्ण अतिथिज्यूलाई आफ्नो स्थानमा राष्ट्रिय गानको लागि उभिदिनु हुन अनुरोध गर्दछु।
Stepping forward, next I would like to request our chief guest, Dr. Suresh Kumar Kanodia sir, and CEO of Nepalganj Medical College, Mr. Santosh Kumar Biyan sir, for coming upon the stage and lighting the panas and to officially start today's program. पत्रकार नवीन सरलाई पनि आसन ग्रहण गर्नलाई हार्दिक स्वागत गर्दछु।
Now we would like to respect our respected CEO sir, Mr. Santosh Kumar BM, to come upon the stage for sharing a few words on today's program. Please give him a huge round of applause.
Respected Dr. Suresh Kanodia sir, Dr. Kedaar sir, Dr. Nitesh Kanodia, CEO ZeeNepal,
तिताडा बजाउनुहुन्छ होला ल्यापटपबाट अनि रेडी पोजिसन नै नबस्छ।
Dr. Nirajan, Dr. Subedi,
ल्यापटप त्यताडा होला
consultants,
प्रोजेक्टर गरिदिए थियो कि
doctors, and staff. It is my great pleasure and privilege to welcome each and every one of you to this prestigious occasion, the inauguration of Comprehensive Stock Center at Sanjeevani College of Medical Sciences. primary stroke center at ZeeNepal Medical College and launch of continuing medical education program focused on stroke care. This is a major step forward, not just for the institution, but for the patients and the families who will benefit from faster, more advanced and more comprehensive stroke care. Stroke is a leading cause of death and long-term disability worldwide.
Stroke is the leading cause of death and long-term disability worldwide. Every minute matters. This is why we call time is brain in ischemic stroke. We believe in timely, specialized and multidisciplinary care which can be life-saving and life-changing. These new centers is to convert this belief into action. This center is a promise to our community that we are here, ready 24/7, with state-of-art imaging, interventional capabilities, and a dedicated stroke team comprising endovascular neurosurgeon, cardiologist, physician, medical officers, nurses, rehabilitative therapists, and support staff all working together under one roof. We are equally proud to host today's CME event, which brings together distinguished clinicians, thought leaders, and education to share the latest in stroke research and innovations in care pathways. This also creates opportunities for interdisciplinary collaboration. I wish to thank everyone who made this day possible. Our board, our medical leadership, our construction decision teams, administration, and above all the patients and the families who entrust us with their care. Once again, welcome and thank you to our speakers, delegates, partners in care. We are united by a common mission to reduce the burden of stroke through excellence in care, innovation, and compassion. Let us move forward with a purpose and with pride. Once more, I forgot to welcome media. I welcome media also. Thank you.
Good evening and welcome everyone. Myself, Dr. Rizwan, along with Dr. Subanjali. सबैजना उपस्थित भइदिएकोमा धेरै धेरै धन्यवाद व्यक्त गर्न चाहन्छु। आजको हाम्रो सेमिनार इस्केमिक स्ट्रोकको बारेमा हो। As Sir had said, ischemic stroke is the leading cause of the disability and mortality worldwide. So timely and evidence-based intervention can significantly improve the patient outcome. Imagine a 55-year-old male came in our ER with slurring of speech and weakness of the limb. The clock is ticking. What we can do next decide his future. So for this 5 year of all restricted faculty of the Sanjeevani College of Medical Science and NGMC will guide us with their great skills, years of experience and knowledge.
आजको हाम्रो सेसन 6 जना प्रेजेन्टर हुनुहुन्छ र प्रत्येक प्रेजेन्टरले 10 मिनेट दिनुहुन्छ जसमा 8 मिनेटसम्म he will be explaining about the topic and 2 minutes will be for question and answer session.
आजको CME will cover pathophysiology, acute management, radio diagnosis, cardiac implications, advanced therapy and surgical intervention.
Without further delay, let's proceed with our first session. It's my honor to invite Dr. Manish Pakshapati, Senior Consultant Neurosurgeon of Sanjeevani College of Medical Science to deliver his talk on understanding of stroke.
Give a big round of applause.
First of all, I'd like to welcome you all for this CME program that we have organized today. And today I'll be talking about just the introduction to stroke and comprehensive stroke care unit. Basically, I'll be focusing on the few parts of stroke and on the unit that provides specific care for the stroke patients. So now to move on to the topic. So this is the brief outline what I'll be talking about. I'll be talking about the definition of stroke, incidence and prevalence, classification, and so on. So first we start with the human brain. We need to know a few things about brain. Just two major points that I would like to focus is that the brain is a complex organ and there are over or more than 100 billion neurons or nerve cells in brain. The other thing is that being a complex organ, it requires a huge amount of blood supply to maintain its normal regulation or function. The brain, it requires about 20% of the total blood pumped by the heart for constant supply of oxygen and glucose. Now, stroke, to move on with, what is stroke? And stroke लाई हामीले कसरी define गर्ने भन्दाखेरि it is a sudden onset of focal neurological deficit or dysfunction that is attributed to focal vascular insult. For example, कुनै कारणले गर्दाखेरि भेसल्सहरुमा इन्जुरी भयो अथवा ब्लड सप्लाईमा ह्याम्पर भयो भने जुन सिम्पटमहरु आउँछ त्यसलाई नै हामी स्ट्रोक भन्छौं. नेपालीमा भन्नु पर्दाखेरि हामीले यसलाई पक्षघात, मस्तिष्क पक्षघात भनेर भन्छौं. And the symptoms in stroke persist for more than 24 hours. Now, talking about the incidence and prevalence, when we look at the worldwide scenario, there is rise in the cases of stroke recently. The stroke is now the second leading cause of death and third leading cause of disability worldwide. How prevalence or how high is the incidence? In every 3 seconds, one person somewhere in this world is suffering from stroke, new patient. And per year, the new cases of stroke is around 12.2 million. That means हरेक वर्ष नयाँ केसेस भनेको 1 करोड 22 लाख हुन्छ स्ट्रोकको. हैन? So now अर्को कुरा भनेको के भन्दाखेरि the next thing, now the stroke is moving on to the younger population. So over the age of 25 years, 1 in 4 people, त्यो भनेको 4 जना मध्ये 1 जनालाई they will experience stroke in their lifetime. And when you look at the global burden of stroke, that is global stroke death and global disability, 89 to 90% of stroke that happens in the developing countries. त्यो भनेको हाम्रो जस्तो विकासोन्मुख देशमा चाहिँ 80 to 90% of the cases हुन्छ. नेपालको सिनारियोमा the prevalence is around 2000 to 2500 per 1 lakh population. And nowadays 63% of stroke is occurring in the younger people less than 70 years of old. So it is now that it's no longer a disease of elderly. When we look at the global burden of the disease, right, this here, this blue, it shows the global incidence, and the red one, the incidence in Nepal. When you look at the global scenario, the incidence of the disease is more in female as compared to the males. But in Nepal, it's just the opposite. That is, it is higher in males and lower in females. And the mortality, when we compare, it is higher in Nepal compared to the world. And when you look at the data of last 15 to 17 years, the prevalence of stroke has increased by more than 50% in Nepal. Now, what it was done that अहिलेसम्म के भन्थ्यो भन्दाखेरि हामीले हार्ट अट्याक भएर मान्छे मर्छ, हार्ट अट्याकले नै धेरै मान्छे मरिरहेछ भनेर भन्छौँ. But when you look at the scenario, there's a paper in 2020, age standardized 30-day mortality rate हेर्ने हो भने the combined mortality due to hemorrhagic and ischemic stroke is more as compared to the heart. हैन, हार्ट अट्याकबाट मर्ने मान्छे भन्दा स्ट्रोकले मर्ने मान्छे अहिले चाहिँ संसारमा धेरै छन्. हैन? So it is high time that we shift our focus to the disease which is causing and which is having more burden in the society. Stroke basically classify गर्दा हामीले there are 2 types of stroke, ischemic stroke and hemorrhagic stroke. Ischemic भन्नाले कस्तो भन्दाखेरि blood supply, blood vesselsहरु occlusion भयो जसले गर्दाखेरि blood supply राम्रोसँग पुगेन भने ब्रेनको सेल्सहरु मर्न थाल्छ. त्यसलाई चाहिँ that we call it ischemic stroke. On the other hand, when there is rupture of the vessels, नसाहरु रगत नसा फुटेर रक्तस्राव भयो, रगत बगेर हुने त्यसलाई चाहिँ हामी हेमोरेजिक स्ट्रोक भन्छौं. If you look at the distribution of the stroke, worldwide, the incidence or the prevalence of ischemic stroke is more than the hemorrhagic stroke, and the same is in Nepal also. But when we compare the global scenario and Nepal, the incidence of hemorrhagic stroke is higher compared to the world. Now, today's focus is mostly on the ischemic stroke. So I'll be focusing on ischemic stroke only. Ischemic stroke is the most common type of stroke, and it occurs secondary to occlusion of the cerebral vessels. The one thing that we all need to know, I think most of all are medical persons here. So हामीले थाहा पर्ने कुरा भनेको पेनम्ब्रा भन्ने हुन्छ. What is पेनम्ब्रा भनेर? First thing is the ischemic core. ब्रेन को जुन ठाउँमा चाहिँ रगत नपुगेर ब्रेन मरेको हुन्छ अथवा सेन्टर भन्छ त्यसलाई चाहिँ हामी इस्केमिक कोर अथवा अम्रा भन्छौँ. एन्ड द रिजन सराउन्डिङ द इस्केमिक कोर or अम्रा इज कल्ड पेनम्ब्रा, where the blood supply is critically low, and the target of our acute management is this penumbra, because if we can restore blood supply or we can reperfuse penumbra region on time, we can salvage it, save it, and thus decrease the burden of or we can say disability which is caused by stroke. So the target of our treatment is to revive the blood supply in this penumbra region. If you look at this picture, this is the milder form, moderate and severe. This denotes the ischemic core and the surrounding tissue blue. यो भनेको चाहिँ penumbra region हो. So as the time goes without giving any appropriate treatment, this penumbra region goes on dying and it will change into ischemic core अथवा त्यो मर्दै जान्छ and will cause irreversible damage. Ischemic stroke हुने कारणहरु चाहिँ मोस्टली भनेको थ्रोम्बोटिक हुन्छ, अर्को इम्बोलिक. थ्रोम्बोटिक भनेको चाहिँ there are thrombus inside the blood vessels जसले गर्दाखेरि there will be gradual decrease in supply of the blood and it will result in ischemia and infarction. Embolic stroke भन्नाले चाहिँ अब कार्डियो इम्बोलिक भन्छ. फर एक्जाम्पल ब्लड चाहिँ नि मुटु भित्रै जम्यो भने ब्लडले पम्प गर्दाखेरि त्यो जमेको रगत पम्प गर्दाखेरि डिस्टल्ली सानो सानो आर्टरिजहरुमा गएर ब्लड अक्लुजन गरेर हुने स्ट्रोकलाई चाहिँ हामी इम्बोलिक स्ट्रोक भन्छौं. In short about pathophysiology, what I showed in the first slide is brain it requires huge amount of blood supply, that is around 20% of the blood pumped by the heart. So normal cerebral blood flow it should be maintained at around 50 to 55 ml per 100 gram of brain per minute. This is required for the normal functioning of the brain. So because of any reason there is occlusion in the blood vessels and the blood supply goes down up to 15 ml per 100 gram brain per minute, then it will result in electrical failure of the neurons. So at this point the ischemia starts and will start having symptoms just dizziness होला, vertigo होला, loss of consciousness अथवा बेहोस हुने, seizure आउने हुन सक्छ. So at this point if we cannot institute any form of appropriate treatment and as the blood supply decreases beyond this to around 10 ml per 100 gram of brain per minute, then the neuronal death will start. Neuronal death means it will result in infarction, which is an irreversible change. So the main aim of our treatment is to restore blood supply before it reaches to this critical level and thus save the ischemic penumbra. Now हामीले स्ट्रोकमा चाहिँ के भन्छ भन्दाखेरि टाइम छिटो गर छिटो इन्भेस्टिगेसन पठाऊ भनेर भन्ने हो. Why do we focus on time so much? If we look at the normal aging person, normally एज भइरहेको मान्छेमा हेर्नु भने every year there will be loss of around 31 million neurons, भनेको around 3 करोड न्यूरोन्सहरु चाहिँ वर्षपछि मर्दै जान्छ यो चाहिँ नर्मल एजिङ प्रोसेसमा. अनि हामीले if you look at the stroke with large vessel occlusion, every minute एक मिनेटमा एभरेज पर्सनमा 1.9 मिलियन न्यूरोन्स, त्यो भनेको अराउन्ड 19 देखि 20 लाख न्यूरोन्सहरु एक मिनेटमा मर्छ र 14 बिलियन साइनाप्सेस, त्यो भनेको अराउन्ड 1 करोड भन्दा बढी साइनाप्सिस भनेको नर्भ्सहरूको कनेक्सन्सहरू लस हुन्छ. सो बिकज अफ एनी कजेस देयर इज डिले इन ट्रिटमेन्ट. सपोज फर इक्जाम्पल 1 घन्टासम्म पनि ट्रिटमेन्ट पाएन भने this will result in damage which is equivalent to neuronal loss of 3.6 years in normal aging. त्यो भनेको 3.5 वर्षमा एजिङ हुँदाखेरि मान्छेले जति न्युरोन लस गर्छ, स्ट्रोक भएको मान्छेमा ट्रिटमेन्ट पाएन भने 1 घन्टामा त्यति धेरै न्युरोन्सहरू लस हुन्छ. सो दिस इज द रिजन वाइ वी हेभ बिन फोकसिङ अन टाइम, है. एन्ड द्याट्स वाइ वी सेड टाइम, वी गो अन सेइङ टाइम इज ब्रेन, समय नै मस्तिष्क हो भनेर इस्केमिक स्ट्रोकमा भन्ने कारणै यही हो. So if you can prevent this much of loss, त्यसले गर्दाखेरि significantly we can change the outcome. Risk factors for stroke, ischemic stroke, there are basically 2: non-modifiable and modifiable risk factors. Non-modifiable gender, family history, increasing age, history of stroke भयो. त्यस्तै modifiableमा चाहिँ नि अहिले धेरै हुने hypertension, smoking, obesity, diabetes, unhealthy diet, high cholesterol सबै पर्न जान्छ. र नेपालमा बेसिकली धेरै हुने भनेको स्मोकिङ, हाइपरटेन्सन, ओबेसिटी र रिसेन्टली डायबिटिज पनि. एन्ड द च्यालेन्जेस द्याट वी आर फेसिङ फर द ट्रिटमेन्ट अफ स्ट्रोक इन नेपाल. फर्स्ट इज आवर कल्चर. हाम्रोमा जीवनशैली रहनसहन कस्तो भएको छ भन्दाखेरि देयर इज रिमार्केबल सिफ्ट टु द वेस्टर्न कल्चर. फुड हेबिट्स, लाइफस्टाइल एन्ड एभ्रिथिङ हेज चेन्ज्ड, which has resulted in increase in dyslipidemia, diabetes, central obesity, hypertension. यो सबै कारणले गर्दाखेरि the incidence of stroke is on rise. Second thing is significant population. हाम्रो एरियामा भने significant population they live in scattered way in rural areas who have less access to the health facilities. And the other thing is health facilities को नजिकै बसे पनि our एरियामा चाहिँ द पपुलेसन दे ल्याक अवेरनेस अफ द रिस्क फ्याक्टर्स अफ स्ट्रोक, द इम्पोर्टेन्स अफ टाइम इन स्ट्रोक. एन्ड फाइनल्ली द थिङ इज बिकज अफ अल दिस थिङ्स देयर इज डिले इन टाइम विन्डो फर ट्रिटमेन्ट इनिसिएसन. किन भन्दाखेरि स्ट्रोक भएको थाहा पाउनै टाइम लाग्छ र स्ट्रोक भइसकेपछि कहाँ जाने, कुन ठाउँमा जाने भन्दा भन्दै टाइम लस भइसकेको हुन्छ. सो दिज आर द मेजर च्यालेन्जेस द्याट वी आर फेसिङ इन द ट्रिटमेन्ट अफ स्ट्रोक. Warning signs, clinical features will be dealt by next speaker. Now I'll be focusing on the stroke care centers. Oile stroke care center it's been divided into two types: primary stroke care center or comprehensive stroke care center. The basic difference of primary and secondary comprehensive ma ke farak bhanda primary ma they provide standardized evidence based stroke care, and they have dedicated stroke units and beds, and most importantly trained personnel to differentiate stroke and its mimics. And finally they have the capacity to administer IV thrombolytic agents for ischemic strokes. Apart from that, comprehensive stroke center ma ke farak huncha bhanda they will be doing all these things. But apart from these, what they have is a dedicated neuro-intensive care unit with additional 24/7 availability of trained personnel with intravascular facilities. त्यो भनेको क्याथ ल्याब भएर इन्टरभास्कुलर फ्यासिलिटिज भएको ठाउँलाई चाहिँ आजकल हैन अहिलेलाई चाहिँ कम्प्रिहेन्सिभ स्ट्रोक सेन्टर भनेर क्लासिफाई गर्छ. पहिला प्राइमरी, सेकेन्डरी, टर्सियरी भन्थ्यो. अहिलेलाई चाहिँ स्ट्रोकलाई कस्तो भन्दाखेरि इमिडिएट ट्रिटमेन्ट गर्नुपर्ने भएकोले प्राइमरी एन्ड कम्प्रिहेन्सिभ दुईटामा मात्र डिभाइड गर्छ. And this is the basic difference between primary and comprehensive center. This is one of the pathway for the treatment of stroke patients. For example, this is a pathway for comprehensive stroke center, and this for the primary stroke center. In case of LVO भनेको large vessel occlusion भएर ठुलो रगत नसा occlusion भएर हुने स्ट्रोकमा पेशेन्टलाई कसरी ट्रिट गर्ने भन्ने प्रोटोकल छ. अब स्ट्रोक भयो, मान्छेले थाहा पायो, एम्बुलेन्सबाट ट्रान्सपोर्ट गर्यो. इफ द कम्प्रिहेन्सिभ स्ट्रोक सेन्टर इज नियर बाई, when they reach the comprehensive stroke center, then after arrival the TPA is initiated within 30 minutes of arrival after all the diagnosis. After this, within 60 minutes that is the puncture is done. त्यो भनेको क्याथ ल्याबमा लगेर क्याथ ल्याबमा मेकानिकल थ्रोम्बोटोमी त्यो गर्ने प्रोसेस स्टार्ट भइसकेको हुन्छ कम्प्रिहेन्सिभ स्ट्रोक सेन्टरमा विदिन 60 मिनट्स. प्राइमरी स्ट्रोक सेन्टरमा चाहिँ के गर्छ भन्दाखेरि दे अल्सो हेभ द क्यापेसिटी टु गिभ आइभी थ्रोम्बोलाइटिक एजेन्ट्स. So they will be giving TPA within 30 minutes. The next what they will be doing is DIDO, त्यो भनेको डोर इन डोर आउट, त्यहाँ आएर प्राइमेरी स्ट्रोक सेन्टरमा स्ट्रोक पेसेन्ट डायग्नोज भएर त्यसपछि यो ट्रिटमेन्ट टिपिए दिएर विदिन 30 मिनट्स दिएर सिफ्ट टु द कम्प्रिहेन्सिभ स्ट्रोक केयर सेन्टर विदिन 60 मिनट्स। त्यसपछि कम्प्रिहेन्सिभ स्ट्रोक सेन्टरमा गइसकेपछि विदिन 30 मिनट्स पङ्क्चर गरेर क्याथ ल्याबमा गएर मेकानिकल थ्रोम्बेक्टमी के गर्ने त्यो विदिन 30 मिनट्स इनिसिएट गरिन्छ। सो दिस इज द बेसिक डिफरेन्स बिट्विन comprehensive and primary stroke center in the treatment of stroke patients. So this is the flow chart for the comprehensive stroke center. When you look at this, there are a lot of parts, a lot of personnel involved, and this is a multidisciplinary. It consists of a multidisciplinary team who are running the stroke center. So हामीले यहाँ बेसिकली हेर्दाखेरि हस्पिटल हेर्छौँ, रजिस्ट्रेसन हेर्छौँ, रेडियो हेर्छौँ, रेडियोलोजी, and त्यसपछि rehabilitation center. We look at all these things, but there are silent partners also in comprehensive stroke care center अथवा unit who play a very crucial role in running this center. त्यो भनेको laboratory test, lab, medicine delivery, pharmacy, meals भनेको nutritionist भयो, त्यसपछि clinical examination and physiotherapy, त्यो भनेको delayed stroke मा physiotherapy and rehabilitation. They all play a very important role in the management of overall and holistic management of stroke patient. What are the benefits of comprehensive stroke unit? भन्दाखेरि reduced morbidity and mortality, shorter hospital stay, improved functional outcome, and better coordination and follow-up of the patients. These are the benefits. Lastly, I would say we have already formed, we have already formed a comprehensive stroke care center at our hospital in Nepalganj, and these are the members who are within the comprehensive stroke care team. We have members from neurosurgery, medicine, cardio, radiology, anesthesia, emergency, lab and cath lab, intensive care unit, pharmacy, rehabilitation, and even from the management. Management also plays a very important role in comprehensive stroke care team, because they are there to ensure smooth running of this team and this center. And I also like to say one thing. We have already established primary stroke care center and at NGMC Bolpur and comprehensive stroke care center at Nepalganj Hospital. So if any one of us or others who are working at other centers want to further develop their center as a primary stroke care center, we are here ready to collaborate with them so they can upgrade their centers. Your sabai target aim because the patients suffering from stroke, they readily get this now readily available services. We can contribute something to decrease the burden of the society. And finally, take home message: stroke is a highly preventable disease, and it's a medical emergency requiring immediate care. Comprehensive stroke unit offers comprehensive multidisciplinary care with improved functional outcome, and early treatment and rehabilitation. It leads to better outcome. Thank you. Questions? Any questions? Please. Thank you.
So before moving forward, I would like to welcome Director of Nepalganj Hospital, Dr. Bhagavathi Goy sir, to please be seated and please the pride of this event. Thank you, Dr. Manish, for your comprehensive overview of the stroke mechanism and clinical manifestation. Your presentation बाट हामीले बुझ्यौँ इस्केमिक स्ट्रोक हुने कारण ब्रेनको कुनै भागमा ब्लड सप्लाई सडनली रोकिन्छ, युजुअली इन्टु ब्लड जसलाई हामी थ्रम्बस या इम्बोलस भन्छौँ। सरले एक्सप्लेन गर्नुभयो ब्लड फ्लो स्टप हुँदा टिस्युमा अक्सिजन एन्ड ग्लुकोज कमी हुन्छ, जसले गर्दा न्युरोन्स ग्रेजुअली डेथ हुन्छ र प्रत्येक 1 मिनेटमा एप्रोक्सिमेटली 2 मिलियन न्युरोन्सको डेथ हुन्छ। So time is brain. Now we understood what is happening inside the brain during the stroke. So it's the time to focus what we can do outside the brain to save the brain. it's my honor to welcome Head of Department of Medicine Unit of ZeeNepal College of Medical Science, Dr. Asim Kidwai, to put lights on the acute management of the stroke and its golden period. Give a big round of applause.
There are a lot of things have been talked about by Dr. Manish about regarding what is stroke, stroke features or initially के हुन्छ, stroke treatment किन important छ भनेर. So I'll just start with the features. Usually stroke मा चाहिँ different type of features हुन सक्छ, but as a summary of all the features, what we say is we call it a focal neurological deficit. भनेपछि कुनै टाइपको एउटा बडीमा एउटा फोकल न्यूरोलॉजिकल डेफिसिट देखिन्छ बडीमा. So that can be of various type. It could be in ways it can present as a balance issue. So sometimes patients present with features like disbalance, ataxia, difficulty in coordination and dizziness. Sometimes patients have issues in the eyes like blurred vision, diplopia, sometimes even drooping of eyelids. Sometimes there are issues in the face like drooping of one side of face, inability to move one side of the face, or sometimes even leakage of saliva from the mouth, sometimes deviation of face. Similarly, a lot of patients present with weakness of one side of the body, the upper limbs and the lower limbs, which is also called as hemiplegia. So हामीले normally हेर्दाखेरि चाहिँ यस्तो हात खुट्टा नचल्ने बिरामीलाई चाहिँ प्यारालिसिसको पेशेन्ट भन्छौँ in general language in most of the cases. So other than that, speech issues, this is one of the unrecognized symptoms. A lot of patients come ataxia, disbalance, and speech issues are something which is missed a lot. So a lot of patients come with speech issue. Some are unable to speak, some do not have a clarity of speech, some do not have the understanding. So धेरै type of presentation हुन्छ. Rather than getting into details, this is just a summary of the types of symptoms that a stroke patient can present with. अनि कहिलेकाहीँ चाहिँ एकदम severe headache भएर पनि patient present गर्छ. So severe headache can also be a symptom of this stroke. So as per the site of the stroke, there can be various symptoms. We don't have time to get into the details of all this, but brain को blood supply is say different arteries but a different part मा हुन्छ. अब brain को different segments ले different functions of the body like control गर्छ. So जुन part मा blockage हुन्छ, त्यो blockage ले गर्दा चाहिँ अब कुन part मा effect भएको छ, कुन part को blood supply चाहिँ कम भएको छ, त्यसमा चाहिँ त्यसमाथि चाहिँ सबै clinical presentation depend गर्छ. So if the blood artery of the middle cerebral artery, for example, is affected, then usually the patient will have some sort of hemiparesis along with speech issues. If the posterior circulation is affected, then patient might present with just dizziness, ataxia, speech issues. So different, depending on the type of the vessel which is affected, the symptoms might vary. We don't have time to discuss each of these syndromes in detail, but there are some things which need to be understood as stroke or paralysis problem is not only hemiparesis. हात खुट्टा नचल्ने मात्रै paralysis होइन. A lot of patients present with just dizziness, रिङ्गटा लाग्ने, चक्कर लाग्ने, उभिन नसकिने यस्तो प्रब्लम्सहरु चाहिँ commonly हुन्छ. And this is one of the things which is missed a lot because they have similar symptoms to many other diseases, as we'll see later on. Moving on, so there is a certain term called as stroke mimics. This includes all those diseases which present with similar symptoms to stroke. They have very common features and it is sometimes difficult to differentiate whether it is a stroke or a stroke mimic. And why is it important to recognize these? The importance lies in the fact is because if we are unable to recognize these stroke mimics, that delays the treatment of the stroke patient itself. And as Dr. Manish has already said, time is brain. The more we delay the treatment, the worse is the result. The worse is the sequelae. So that is why early recognition is very important. So some common diseases which presents with similar symptoms to stroke are, one very important is seizure. So seizure पछि चाहिँ because of the abnormal movement, हात खुट्टा हल्लेर कहिलेकाहीँ weakness develop हुन्छ. So this is known as Torch palsy. So this is similar to stroke because the stroke patient also presents with some sort of focal deficit like hemiparesis, and these patients also present with some sort of deficit. The differentiation is we'll talk about later on. Similarly, migraine को एउटा type हुन्छ hemiplegic migraine. त्यसमा पनि similar picture हुन सक्छ. Metabolic diseases and toxic conditions like hypoglycemia, sodium disorders like hyponatremia, even hyperkalemia can present with deficits which can be similar to stroke. Brain tumors, mass lesion, syncope or fainting because of decreased circulation, because of dehydration or cardiac issues or arrhythmias, and functional neurological disorders because of panic attacks. These are all very common differential diagnoses of stroke. So we'll just discuss in brief about how to differentiate them. Seizure चाहिँ Usually, seizure ma patient ko weakness, say abnormal movement पछि develop huncha. In cases of stroke, usually the focal deficit or the weakness is previous, and seizure might occur, but it occurs later. So, पहिला abnormal movement भएको छ, त्यसपछि weakness भएको छ भने that is very likely to be because of seizure, and it usually recovers within the first 24 48 hours. So, this is one of the ways by taking history we can differentiate. Other than that, hypoglycemia एकदमै common कुरा हो जसमा चाहिँ patient comes with altered consciousness. The basic difference between these two is hypoglycemia, usually patient has a history of preceding illness like diabetes or taking any sort of medications for diabetes or some other illness, not eating properly, fasting or taking medications without taking insulin, without taking any food. So, it's the previous history huncha. Plus hypoglycemia ma patient usually has a generalized picture, not a focal deficit most of the times. It can present, but it is not very common. Plus hypoglycemia gets corrected very quickly by giving dextrose. So this is one of the things that we always check in the emergency. If a patient comes with altered consciousness or focal deficit, any sort of deficit, we check for glucose levels and we correct the glucose level and see if it gets reversed. Similarly, migraine ma चाहिँ patient को there's a long history of headache with aura भनेको चाहिँ visual field मा चाहिँ यस्तो झिलमिल देखिने त्यस्तो टाइपको अरू multiple issues हरू हुन्छ. It can be of various types. So there is a history of aura, usually a younger age of onset, and usually there is a history of past attacks as well. Bell's palsy चाहिँ slightly difficult हुन्छ differentiate गर्न because it also causes paralysis of the face. Stroke ma most of the times the paralysis is only of the lower part of the face, the upper part of the face is spared. In Bell's palsy both are involved. Obviously in some diseases, when the location is in the brainstem, then both upper and lower both can be involved, but in those cases usually other cranial nerves are also involved. So that is one of the things. Plus there is no hemiparesis or involvement of upper limb and lower limb in cases of Bell's palsy, which is there in cases of stroke most of the time. Functional is something which is very common. Anxiety भएर आत्तेर functional tension भएर कतिजना चाहिँ हातखुट्टै नचल्ने समस्या भएर आउनुहुन्छ इमर्जेन्सीमा. Now this is something which we need to differentiate because the urgency of treatment is not there in here. So that's one of the typical signs which we see in this is the symptoms of these patients keeps on changing. So sometimes they'll have weakness in one side, then sometimes on the other side, and when we divert the mind of the patient, sometimes the symptoms disappear. So the timing, the appearance, disappearance of symptoms, the correlation with the neuroanatomy is usually not there. There's a test known as Hoover's sign. We cannot discuss in detail right now, which is done to see if the patient is voluntarily controlling the limb or is it actually weak. So that we can do. Brain tumor or any mass or any intracranial space occupying lesion in the brain, that can cause this. Usually you have history of headache, vomiting, seizures in the past. Encephalitis, meningitis, usually there is history of fever. And then there's a disease, multiple sclerosis, which can also present with various type of weaknesses. But in this, usually eye involvement, bladder involvement is there. It usually comes and goes. And then there is, while examination, because of optic neuritis, we might find RAPD. And these patients also have increased symptoms in heat. So while taking a hot shower and all, the symptoms might increase. Other than that, various types of diseases like chronic renal failure, chronic liver failure, electrolytemias, toxicities of various substances like alcohol can also present. So it is very important to differentiate this clinically, and this has to be done very quickly. The next step would be imaging after that. So CT scan and MRI, which will be discussed in the next by the next speaker. Now this is after clinically examining and ruling out the stroke mimics, and when we think that this is probably mimics, this is one of the things which is very much required to assess the patient. This is known as the National Institute of Health Stroke Scale or NIHSS. This is a systematic assessment tool used to evaluate severity of a sudden stroke in a patient. It has various headings. It has 11 points under which we evaluate the patient and give the patient a certain score. That score is very much important for the prognosis, for the diagnosis, for multiple things. So the first advantage of using this score is this standardizes the severity of the disease. Right now what happens is one doctor might see the case and might feel this is a mild disease. The other might say this is a severe disease. So there is no standardization about the severity of the disease. So if you use this score, this helps in standardizing the disease across the board. Whoever sees the disease will have the same score. So it won't depend on the treating doctor. Similarly, it also helps in treatment decision making. A patient, as we'll see in the later on, which patient require what type of treatment. A lower score means a milder disease. So a lower score patient with a lower score might not need much treatment, with a higher score might need much more treatment. Similarly, it also helps predict the outcome. It is also related with the prognosis. Lower score means less mortality, higher score means much more higher mortality. Like a score of around 4 is around 4 to 5% mortality. Score of more than 20 usually can be up to 50% mortality. And also in a patient, stroke patients usually take a long time to recover. During that period of time, this helps in monitoring the progress of the patient. So NIH's score, there are various headings, I'm not getting into the details, but level of consciousness, gaze, visual, field, facial palsy, motor, arm and leg power, ataxia, sensory, language, dysarthria, all these points are included, and in the end the score is given between 0 to 42. If the score is 0, that means there are no symptoms of stroke. If the score is between 1 to 4, that means it's a minor stroke with a mortality less than 4%. If it is between 5 to 15, it is moderate stroke. 16 to 20 means moderate to severe, and more than 20 means usually a very severe stroke with mortality expanding up to 50%. So this not only helps in deciding whether the patient, in a lot of patients when we are confused as what to treat, how to go ahead, this score really helps us a lot, as we'll see in the upcoming presentations as well. It also, like we've already discussed, it predicts the outcome. And one very important thing is it helps us to decide whether the patient needs ICU care or not. So in a place where we have shortage of beds, this might be a very handy tool because of multiple reasons. After assessing the patient, we quickly get on with the initial management part. In initial management, like any other disease, we first assess the vitals, maintain the CAB, and try to take a rapid history. Now, as it's already been discussed, the time is of value. Time is brain. The more we delay the assessment, more will be the damage, and the damage is irreversible. We've been doing this, treating these cases for a quite long period of time, but the problem is we do not treat this as seriously as we should, not like heart attacks or myocardial infarctions. Both have the same pathophysiology, both are very time sensitive issues, but this is a more time sensitive issue. So in this case, mostly we should ideally try to treat it as soon as possible. So the assessment, all that inclusion, ruling out the cerebral mimics, the NYSS scoring, everything has to be done rapidly, within minutes. And then fluid management, checking for swallowing is very important because most of these patients are unable to swallow, and one of the biggest risks and complication in such patients is aspiration, which leads to pneumonia. So assessment of swallowing is very important. Blood sugar has to be managed, both hyper and hypoglycemia have to be managed. Then blood pressure. Now this is one important part. Blood pressure as a reflex. Whenever we see a patient of high blood pressure, we tend to want to decrease it as quickly as possible. Now this is something which is different in a patient of stroke. Ischemic stroke ma high blood pressure lai ghataunalai hatar garnu huँदैन. We should always try to decrease it slowly. Ischemic stroke, most of the patients have high blood pressure not only because they have hypertension. It also occurs as a reflex because of various mechanisms, because of auto-regulated autonomic nervous system, or because of disruption of the cerebral perfusion. So it might be sometimes protective. In fact, all these trials, the International Stroke Trial, MAPAS, RIDE2, CATIS, CAST, all these trials have shown that if we decrease the blood pressure very quickly, it leads to worse outcome and poorer prognosis. So this is a reflex that we all have to understand. This is one of the most important things, that blood pressure in ischemic stroke should not be decreased very quickly within the first 24 hours. Of course, there are some exceptions. If the patient has some other disease like concomitant heart failure, you'll have to decrease. If you're planning for thrombolysis, you'll have to decrease. But unless these two things are there, you should not try to decrease it. And the target, the level above which we try to decrease is 220 by 120. It sounds very scary, but up to 220 by 120, we should not hurry to decrease the blood pressure in cases of ischemic stroke. Because most of our medical officers and residents who will be attending the cases at first go, it is a reflex that whenever case comes, we hurry to decrease the blood pressure. This is the only, if you remember anything, just remember this, do not decrease the blood pressure very quickly, okay? Then we assess for eligibility for thrombolysis. The target for blood pressure is different for thrombolysis. It is less than 185 by 110, so we'll have to give some drugs. So the only reason for decreasing blood pressure is if we are wanting to thrombolyze the patient. And then antiplatelet. Now this is another thing that we do not do routinely. Most of the patients who are candidates for thrombolysis should not be given antiplatelets initially, first thing. And every other patient, unless contraindicated, should be given. Dual antiplatelets can also be given, single antiplatelets can also be given. Now dual antiplatelets is given in certain conditions, like when the ABCD score that we'll see later on is more than 4, or when the stroke is of a minor category, less than 5 score, through the NIHSS scoring. So multiple trials have shown that dual antiplatelet using both aspirin and other antiplatelets for the first 21 days especially, and up to 90 days helps significantly in decreasing the recurrence of stroke. Beyond 90 days, they increase the chance of bleeding with less prevention. But initial between 21 to 90 days, dual antiplatelets should be used in cases who fit this criteria. Other than that, anticoagulants can be used, which will be discussed by our next presenter, and statin therapy by using drugs like atorvastatin, rosuvastatin. These drugs, they are very helpful in not only decreasing the atherosclerosis plaque, but also help indirectly by various other mechanisms. So they should be used. So what about the thrombolysis? These are the indication and contraindication of thrombolysis. It should be used within 4.5 hours for eligible candidates. The blood pressure should be less than 185 by 110. The other various contraindication and indications are there. I won't get into the details. Two drugs which are commonly used are alteplase and tenecteplase. We've used them here. We've done 3 cases. One case was done 5 years back. 2 cases recently done by our neurotime recently over the, I think, last 4-5 months, and all the cases had wonderful results. So this is something that I think should be put into trend. And this is the ABCD scoring that we were discussing. So in the end, the take-home points overall are that stroke itself, ischemic stroke, has high morbidity, high burden. It has much more burden on the family and the patient than any other myocardial infarction or anything. Mortality is a different issue. But a paralyzed patient is dependent on others. They cannot do things by themselves. So it's not just a financial burden. It's a very big social burden as well. So the only way to prevent is timely management. But because of the trend, I don't know what is the reason, we are not sure. Maybe because of lack of awareness, we are still unable to thrombolize, I think, 99.9% of cases. Maybe we've thrombolized 0.1% of cases. So our focus should be to treat these patients as quickly as possible. Rapid assessment is the key. Differentiating from mimic should be the priority. Scoring should be done for standardization, prognosis and decision making. Blood pressure should be managed. Again, the thing to remember is don't hurry to decrease the blood pressure unless some other indication is there. Assessment for thrombolysis and thrombectomy should be done. And after that, plan for chronic management and management of comorbidities has to be there, because stroke usually occurs because of certain risk factors. Unless we treat those risk factors, it is going to occur again. So just treating the patient is never complete treatment. Patient ko har ek associated illnesses, pressure, diabetes, lipid issues, whatever is there, till I say hamle treat garnai parcha. So with that, I would like to end my presentation today. Thank you. Any questions? Okay, thank you.
We sincerely thanks Dr. Asim Kidwai sir for his insightful presentation. His session has made it evidently clear that early recognition of symptoms and timely intervention is vital in saving lives and reducing long-term disability. So now we have understood pathophysiology and acute management. So keeping the context, time is key for identifying and ruling out the disease. I hereby request Dr. Leknath Baral to take us through the significance of CT and MRI scan in identifying ischemic stroke.
Namaste and good evening everyone. I'm here to present on role of imaging stroke. I myself being Dr. Leknath Baral, and I have made a simple analogy here. Our brain is like garden, and this garden we can see here it needs continuous drip irrigation. And if we imagine there may be 2 disruptions of the irrigations. One may be sometimes the pipes may be blocked, maybe clogged due to some mud or some cobbles, and another may be these pipes may be disrupted or broken or damaged. Both are the analogous to stroke. If there is clogging of the pipes and these plants go wilting, that is like ischemia or infarct. And if there is a rupture of the pipes that leads to flooding, Duban mounds, both are the strokes. And we can imagine which one is dangerous. If there is just wilting of the plants, we can re-irrigate and we can bring them into life. If there is flooding, then it is more dangerous. And this is the brain and these are the pipes or vessels. They are continuously perfusing our brain. Our brain contains trillions of neurons, and they are depending on continuous supply of glucose and oxygen. And if there is some disruption or deprivation in the supply of oxygen or glucose, there ensues a cascade of events that leads to, firstly, ischemia, then ultimately it culminates into infarction. And ischemia is reversible. And if there is full-blown infarct, then that is irreversible. So that ischemic part can be salvaged or saved. So we have to target for that with our modern approach of therapy. And how we aim for imaging, and we have to see the parenchyma, brain parenchyma, and we can rule out hemorrhage. We can rule out hemorrhage because this thrombectomy or IV thrombolysis, they are meant for thrombus or embolic obstruction. And if there is hemorrhage, that is contraindication. And we have to see the pipes and vessels here. We have to see all the neck vessels and intracranial vessels. If there is some dissection or if there is some embolus or thrombi, or we can see atherosclerotic plaques as well. And next part is the perfusion. With the help of perfusion, we can calculate the volume affected, and we can calculate the volume area under risk, and we can calculate that perfusion penumbra area with the help of different scores later on. And this penumbra is the area around the core infarct, and this part is reversible. And regarding the imaging modalities, we have CT scan and MRI. Earlier, before the advent of CT scan and MRI, we used to depend on different clinical symptoms alone. And now we have CT scan and MRI. And this CT scan is readily available, cheaper, faster, and MRI has some limitations, not that readily available, and it is time consuming as well. And in CT scan, we cannot detect ischemic changes. And again, we have to go for the excluding bleeding. We have to rule out hemorrhage, and we have to assess the stroke severity. And we can, if it is within the window period, we can calculate the penumbra area. And this is how infarct looks in CT. This is Y-shaped hypotensial diminished attenuation with mass effects, and this is the hemorrhage. This is like flood. And this looks white in acute stage, and its HU, means attenuation value, goes on decreasing by 5 HU every day. And this is the infarct. And the more black it is, the more older it is. And how we see early signs of infarct, you can see here, this is the MCA, proximal MCA, and this is dense. This is called dense MCA sign or hyperdense MCA sign. And this is usually due to cardioembolic events. And later on, we can see there is, in this normal side, we can see this gray matter and white matter. There is clear-cut demarcation. But in this area, there is a loss of gray-white differentiation. So this is infarct. Now again, in this side, we can see this insular cortex that is a little bit white, but in this side, this is a little bit black, so it is infarct. And most of the time, what we people also, radiologists also get confused that in a cursory look, this looks normal. In a hurried look, this looks normal. But if we change the window setting, this is normal window, and this, if we see this area under different setting with the window width of 10 HU and center at 28 HU, there we can see a area of low attenuation. So this is infarct. This can be easily missed in this normal window. But if we see retrospectively, there is subtle diminished attenuation. And regarding the ischemic stroke, we have to calculate a score, that is aspect score. Why we calculate this is because all the penumbra or all the ischemic areas, they may not be, they may not undergo thrombectomy or IV thrombolysis, because if the area involved is quite large, and if we reperfuse, there may be hemorrhagic transformation. And you know, hemorrhagic transformation or hemorrhage itself is a very dangerous, more dangerous than the infarct itself. So to prevent that hemorrhage or hemorrhage transformation, we have to calculate the score. In this aspect score, we call it aspect score, we have 10 areas here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And these peripheral 3 parts and these 3 parts, they are for MCA territories, middle cerebral artery territories, and these are lentiform nuclei or basal ganglia region. And this is insular cortex. Out of 10, if all are preserved, if there is no change in signals or density, then that is 10 out of 10. That is normal. And if one is obscured, if there is obscuration in the gray-white differentiation, we mention is at 9 by 10. The higher the score, the better is the prognosis. And why we calculate this? Because as per CT aspect score, if the score is less than 6, we cannot go for IV thrombolysis or thrombectomy, mechanical thrombectomy. Why it is so? Because if the area is quite large and if we still reperfuse the brain, that may lead to luxury perfusion and later on hemorrhagic transformation. So to prevent that, we have to calculate this score. And depending on the score, we go ahead. And in this CT images, you can see this basal ganglia looks normal, but this insular cortex is gone. And all the 6 territories of MCA, M1, M2, M3, and M3, M4, M5, M6. So 3, 6, 7 areas are gone. So this has aspect score of 3 by 10. And in this scenario, we cannot reperfuse the brain. Why? Because it may undergo hemorrhagic transformation, and that may have worse prognosis. And we also have the aspect score for posterior circulations, 1 for each occipital lobes and each cerebellum, and 2 for this pons and 2 for this medulla, and 1 for each thalami. Now next comes the CT angiography. Why we need CT angiography is that first we can exclude whether there is occlusion or not. You can see here, this corresponding part is missing here. So this is thrombus. There is occlusion. And another is whether there is some dissection. And we also can calculate the score, collateral score here, grade the collateral blood flow. In the younger population, the collaterals are not that developed, but in the elderly, collaterals are well established. So if there is a same size infarct in young population, that may have bad prognosis. In the elderly, that by the elderly age, the collaterals are well established. So that may again salvage the brain, and we can characterize the plaques also. And this is, we can see here, we can see good number of vessels in these collaterals, and there is paucity of vessels, means indicating poor collaterals. Now, mainstay of the imaging in ischemic stroke is CT perfusion. CT perfusion, we can calculate the area or tissue at risk. And with different parameters like cerebral blood flow, mean transit time, and time to peak enhancement, we can calculate the volume of penumbra or volume of core infarct. There are different, and these are calculated by the software. And there are different color codings that is of concern for we people. And these are the images showing different parameters of the CT perfusion. And in this image, you can see in mean transit time and Tmax, red means bad. And in blood volume and blood flow, red means good. This one is good and this one is bad. And this is just opposite here. And this is bad, this one is bad, and this side is good. So with the help of these cerebral blood flow and Tmax, we can calculate the salvageable tissue. So if we deduct this one from this one, we can get the area under penumbra. This is how software calculates the area of mismatch perfusion. You can see here this one is Tmax image and this one is blood flow image, and this shows that there is in fact core of 161 ml and this one is under 70 ml. So only 9 ml of area is salvageable. Means there are traces of tissues that we can salvage. So this is how we calculate the salvageable tissue. And another modality of imaging is MRI that consists of DWI ADC, FLAIR, and gradient echo. This gradient echo detects hemorrhage, and this diffuser weighted imaging is quite sensitive for early ischemic changes. We can see a restriction here, and this is T2 and FLAIR. We can see, and they retrieve the signals a few hours later. And there is temporal evolution of the signals from different sequence. So we can see DWI, it detects signals earlier and it picks around this time, 24 hours to 7 days. And T2 is quite slow. It picks around this time. This is time frame. And so different sequence of MRI, they detect ischemic changes. And again, there is DWI flare mismatch. This means you can see here, this DWI shows some signals here, but there is no signal in flare. Because flare images they are quite slow, and DWI, they are quite fast. So there is DWI flare mismatch. If the patient comes with these findings, we can make a guess that there is some salvageable area if timely intervention is made. You can see here, there is high signal areas and there is normal. It looks normal. So it is, we can make a guess, it is within the window period. But in this case, DWI and FLAIR both have the same signals. So this is quite a few hours later. So at this time, medical management may be helpful. Here concludes my presentation. Any questions? Thank you.
So thank you, Dr. Lehna, for demonstrating imaging techniques and roles in stroke. I also mentioned that CT scan could be normal in early stages of stroke. So we must remember a normal scan does not always means the absence of pathology. Clinical judgment still remains the paramount. We must be suspicious, particularly in hyperacute window period, that is in early 4.5 hours. Early signs may be subtle or even absent radiologically, but consequences of delays are profound. अब स्ट्रोक को कारण मात्र रगतका नसाहरू बन्द भएर हुने हैन. Many times the problems begin from the heart. Given that cardioembolic events like atrial fibrillation and many more account for significant proportion of ischemic stroke. Our next session focus on critical intersection. It's my privilege to welcome intervention and clinical cardiologist of SCMS and NGMC, Dr. Krishna Chandra Adhikari, who will teach us on cardiac evaluation of ischemic stroke.
Thank you, Dr. Rizwan, for warm introduction, and thank you, my neuroscience colleague, to provide me opportunity to present how our brain and heart are interconnected and what is the role of cardiology department in case of handling the ischemic stroke or the stroke unit, comprehensive stroke unit. Why heart? Because we know that often heart is always connected with brain, and mastiska ra motu सधैँ नै जोडिएकै नै छन्, कुनै पनि कारणले हुनसक्छ हैन, त्यो कुरा चाहिँ हामीले बुझ्नुपर्छ। भर्चुअली एनी कार्डियक प्याथोलोजी contributes to the increased risk of cardioembolic stroke, and we are connected through the risk factors, as the risk factor for ischemic stroke and coronary artery disease are always same or similar. In fact, in some cases, stroke may be the first finding that can be that stroke may be the first presentation of the cardiac disease, which is often undetected throughout his career, like rheumatic heart disease, valvular heart disease, which consists of the mitral stenosis, and it may lead to the atrial fibrillation, and that may come with the presentation of the stroke. And as I mentioned, the risk factor, hypertension, dyslipidemia, all are interconnected to stroke and also with the coronary artery disease. And ESC has also recommended cardiology expertise to handle the ischemic stroke in case of comprehensive as a part of comprehensive stroke treatment. Now, acute stroke, we are seeing this, that most of them are ischemic in 85% of the patient, and it is always related to cardioembolic or large artery atherosclerosis or small arteries lacunas, and it most of the time is always atrial fibrillation or cardiac origin, or embolus from the artery to artery. And coming to the next slide, how we can contribute to the stroke unit. We can contribute always with a diagnostic part, also with etiology, determination of the etiology. In most of the cases, as etiology are always clear, but in some cases we have to find through various diagnostic procedures, which includes the echocardiography or the Holter monitoring or the thoracic as well as esophageal echocardiography, and further even may require the long-term Holter monitoring like loop recorder. And stroke prevention and secondary prevention and subacute part is always a part of a cardiology department to handle it through the stroke department. And it always considers overall, we can contribute to improve both short and long-term outcome of the patient. How we can handle it and what is our job? We have to always detect atrial fibrillation, if there is cardiac thrombus or not, heart failure or not, myocardial infarction associated, which may alter the treatment pathway, aneurysm, valvular heart disease, even infective endocarditis is useful, and there may also be patent foramen ovale, which can be determined by echocardiography. Now, we may also be able to help by handling the acute arrhythmias, blood pressure deviation, when there is a required fluctuation of the blood pressure. And in the secondary prevention, we always can help with the hyperlipidemia, hypertension, and initiation of the therapy. Standard cardiac workup always starts with history, physical examination, and most importantly ECG, blood tests like troponin, BNP, echo, and Holter monitoring. And for comprehensive work of cardiac evaluation, it's always based on medical history, the clinical status, and the stratification of the CV risk factors. Now, when there is a cardiac problem can lead to the stroke, but stroke also can have the cardiac complications. Like cardiac complications are among the most common complications in acute setting, which occurs in 24 to 72 hours of the initiation of the stroke. Requires thorough monitoring and sometimes immediate treatment. Mortality after stroke is significantly higher if CV complications are present. Cardiac complications, the pathophysiology behind that is after the stroke, if it is involvement of the insular cortex, which is a part of the cerebral cortex, they may initiate the inflammatory response to cause the acute coronary syndrome or strain related cardiomyopathy like Takotsubo cardiomyopathy. And there may be also sympathovagal imbalance, which may cause the atrial fibrillation, even ventricular arrhythmias, and progression decompensation of the heart failure. So common problems to solve, it's a hypertension, hypotension, arrhythmias, and prothrombic complications like DVT and pulmonary embolism. Hypertension already discussed by Dr. Asim Kidwai. I'll not go too much on that, but we should always treat the hypertension judiciously. We have already mentioned that if not receiving RTPA or mechanical thrombectomy, you should always treat blood pressure only when BP is more than 220 or 120. And if the patient is receiving RTPA, first exclude persistent BP more than 185, 120 and maintain below the 185, 180, 105 to give a thrombolysis. Check BP every 50 minutes, should not aggressively lower BP, which may even harm the neurons. And for BP control, use labetalol, which is short acting, titrate, IV intravenous 10 to 20 mg, and double dose. It can be doubled every 20 minutes to get to the maximum 300 mg. For a stable patient who remain hypertensive more than 140/90, below 220, 120, you can always start the medication and with a gradual decrement. It is better to avoid nifedipine as it can cause the acute hypotension and which is more detrimental to the neurons. Hypotension, more detrimental, always seek cause like sepsis, shock, low cardiac output, hypovolemia. CVP monitoring is needed, and use 0.9% saline first to ensure adequate preload. And we can start vasopressors if needed. So one thing is always how to, if the patient comes with atrial fibrillation and there is ischemic stroke, how to start the oral anticoagulant in those type of patient. So we have already get the importance of NIHSS score in prognosis and treatment pattern. There is also a role in case of starting oral anticoagulation after stroke in AF patient. We can always follow the 1, 2, 3, 4 rule. If the NIHS score is less than 5 and it is mild type, we can start OAC 1 day after the acute ischemic stroke, and if there is no, like in TIA, we can start immediately. But if there is a mild lesion, then we may wait 2 days to start the oral anticoagulant, and if moderate, 3 days, and if more than if it's severe, then we can always wait up to 1 week to start the oral anticoagulant. So in summary, how we can assess the patient of stroke on the behalf of cardiology is that if we can always prevent primary prevention with even the patient who is not having the stroke, and always look for the cardiovascular risk profile and primary prevention. If there is atrial fibrillation, we can start oral anticoagulant for prevention. And in case of acute stroke, we can help with the acute diagnostic procedure, acute complication, and for post-stroke, there will be the workup for cardiovascular workup like AFib, PFO, heart failure, CAD, and lifelong secondary prevention with management of hypertension and lipids. And in conclusion, it's always important to have an interdisciplinary management which will improve the stroke patient as both heart and brain are related, and it plays a central role in both causal and complicating factor. Treatment and monitoring on a stroke unit are largely driven by control of autonomic regulation on the cardiovascular system and which accounts for a wide range of acute hemodynamic, electrical and myocardial complications. A more profound understanding of cardiac implication in stroke management will improve the integrated stroke care concepts. With this, I'd like to thank you for audience with a patience hearing. Thank you.
Thank you, Dr. Krishna Chandra Adhikari sir, for showing us the ischemic stroke. मुटुमा केही समस्या हुने बित्तिकै हस्पिटल जानुपर्छ भन्ने जनचेतना हामीमा भइसकेको छ. But sadly, when it comes to brain, we are far less careful. It's time to change our perspective. We must stop treating brain as a backup organ, just like heart. Brain also need urgent attention. By saying this, we now turn our attention to advanced therapeutic intervention. I invite Dr. Neeraj Gimile sir to present on this crucial topic.
Today I will be discussing on the topic advanced management of ischemic stroke. The core theme of my topic will be the mechanical thrombectomy with or without IV thrombolysis will be the main state of the treatment. It depends on the duration of the symptoms. Till 2015 AD, the IV thrombolysis was the standard treatment for ischemic stroke. But the trials like Mr. Clean that was conducted in Netherlands and Extend IA trial that was conducted in the Netherlands and Australia changed the whole concept about the management of the ischemic stroke. And the base test has also shown that the IV thrombolysis beyond 4.5 hours of treatment has more hazardous effect than beneficial. That means it will cause symptomatic intracerebral hemorrhage than beneficial in those patients. That's why IV thrombolysis may not be sufficient. So the concept of endovascular mechanical thrombectomy was proven by two trials which I told before, that is Mr. Clean trial and Extend IA trial. What if the patient presents after 4.5 hours of symptoms, or if patient presents in the morning with the stroke? The answer lies here. The given by Downs trial, it was published in 2017. The research was conducted in the United States of America, Canada and Mexico. And another trial was Diffuse 3 trials, which was published in 2018, and the research was conducted in the 32 centers of the United States of America. These two trials says that we can do mechanical thrombectomy behind 6 hours of symptoms. That means if the patient present after 6 hours up to 24 hours, based on the clinical deficits and imaging mismatch. The clinical deficit was mentioned by Dr. Asim Kidwai regarding NIHS scoring. If there is a scoring system is more than 10, NIHS score is more than 10, age is more than 80, and the impact volume is less than 21. And in those patients, we can do a mechanical thrombectomy beyond 6 hours of symptoms. Similarly, if the age of the patient is less than 80 years of age and NIHS score is more than 10 and the impact volume is less than 31 ml, we can do a mechanical thrombectomy in those patients. And the next year, 2018, the diffuse trials told that when they supported the Downs trial result that shows that if the patient present after 6 hours and up to the 16 hours of symptoms onset, we can do a mechanical thrombectomy based on the perfusion scan as discussed by the Dr. Letnath Baral. The Diffuse 3 trial says that if the perfusion scan as done by CT perfusion scan or MR perfusion scan shows that the penumbra means the viable brain that can be prevented from going into the infarct. If that volume is more than 15 ml, if along with that the infarct size is less than 70 ml and mismatch ratio, that means the penumbra divided by the infarct, that is calculated as Tmax. Tmax means maximum time the blood is taken, blood takes to reach the part of the brain. It is defined as the Tmax. If the Tmax is more than 6 seconds, that means there is a ischemia. Similarly, if the cerebral blood flow is less than 30% of the normal cerebral blood flow, that means it's an infarct. The Tmax divided by cerebral blood flow, if it is more than 1.8, that means more area of the brain is viable than the area has been infarcted, has already dead. In those patients, we can do a mechanical thrombectomy within 6 hours. That means, is it that we cannot do IV thrombolysis beyond 4.5 hours of symptoms? In previous slide, which I have told that the various trials have shown that IV thrombolysis beyond 4.5 hours of symptom onset is more hazardous than beneficial. I contradict this sentence with my another slide that says that you can do IV thrombolysis beyond 4.5 hours symptoms, and it's a research process. But there is a debate regarding these things. There are multiple cohort studies, multiple RCTs, few meta-analysis that says that we can do IV thrombolysis even in the patient beyond 4.5 hours of symptoms, but there is a chance that patient may develop a intracerebral hemorrhage. But those patients will be benefited more than we are harming them. Till some consensus comes to some European consensus, American consensus come to giving a final conclusion regarding whether to start 4.5 hours of treatment or not. We will not be doing this in our center because it's still going on. It's still a research is going on. The time is brain, as suggested by Dr. Manish Kolaksepati and Dr. Asim Kidwai, that this image, if you ask me, looking at this image, what is the age of the patient and what is the cause of ischemia, I can tell a bit point in favor of this slide. If you look this imaging, the green area is a penumbra, the red one is a infarct. This is a CT perfusion scan. If this region is calculated as less than 30 ml, 30% of the cerebral blood flow. This area is the area that is divided by, that is minus Tmax minus cerebral blood flow, that is less than 30%. This patient cannot be a young patient. This patient cannot be the infarction in this patient cannot be due to a cardiac cause. Because why? It's because in old age there is a collaterals. In old age the most common cause of infarct is the emboli from the plaque. The plaque that arises from that is in the carotid artery. In carotid artery, the plaque, some emboli goes to the distal part of the MCA, proximal part of the MCA to cause this sort of infarction. They already develop collaterals from the external carotid artery. So, if it's a sudden onset in a young patient, this patient those brain cannot survive for 24 hours. This should be a young patient. Young patient, and the cause should be a cardiac emboli. This patient should be an old patient, and the cause should be a emboli from the plaque that has been originated from the carotid artery. That's why we call it time is brain. This is the image showing how we do a mechanical thrombectomy in the patients. There are two types. You see, this is the aspiration technique. There is a aspiration catheter we put in the proximal part of the clot along with the stent. There is a stent covers that is deployed along the clot, and the aspiration catheter is placed in the proximal part of clot. In stent retrieval along with the aspiration technique, there is a two-way technique that aspiration will suck the blood. Along with that, the stent will have to retrieve the blood into the catheter. It will suck the blood inside it, and this stent will be passing inside it here and through this balloon guiding catheter when we take it out. I'll show you. And here we are not using a aspiration. This is only a stent retriever technique. We are not using a aspiration catheter in this technique. Next, you can see here, this is a clot. This is a clot in the proximal part of MCA. We put a catheter, we call it a micro catheter, through it we are passing the stent. You can see the part of the stent here. We will pass the stent through this catheter inside here, and we'll slowly pull out the catheter. In this way, some part of stent, what will it will do? It will do two things here. It will temporarily push the blood clot into the periphery. So the blood clot that has caused the disruption of the blood flow distally will be reopened, and simultaneously it will also help to drag the clot back into the catheter like this. And this is the final outcome, how we do it. Then what's our plan? At our center, Sanjeevani College of Medical Sciences, Nepal Medical College, we don't have cath lab right now. I think we are going on to buy a new cath lab there. Then after that, we will be converting the Nepal Medical College also as a comprehensive stroke center. Till then, as we will be doing a cath lab procedure in vascular mechanical thrombectomy only in the Sanjeevani College of Medical Science, in which if any patient we diagnose with a stroke and we think that patient we can do a mechanical thrombectomy in those patients, then we'll go for a aspiration technique first. We'll go for 2 attempts of aspiration technique. If despite the 2 attempts of aspiration technique, if it fails, then we'll add on stent retriever techniques. It's because the cost of stent is quite high. It is around 2.5 lakh. If you can reduce the price of the stent from our mechanical thrombectomy, then the cost of the treatment will be hugely reduced, and that will be equivalent to 2.5 lakh. This is the example. You can see there is a clot in the medial cerebral artery, just behind the lenticular artery. This is a superior branch, this is the inferior branch. The more inferior branch is more occluded. If you ask me, and there is a proximal part of stenosis in the supraclavicular part of ICA. If you ask me if this was the post-thrombolysis or post-thrombectomy case, then I would have given this the score. We call it a MTC score, modified thrombolysis in cerebral ischemia. It should be a MTC2A score, but it's not that. It's a before thrombolysis or thrombectomy. So the same patient after thrombolysis, you can see, you can just compare it. This part of the brain has a less flow of the blood. There is a clot, and this post-mechanical thrombectomy. Post-mechanical thrombectomy, you can see the whole superior branch and inferior branch has fully opened, and this is a complete revascularization. We call it a modified thrombolysis in cerebral ischemia. In fact, score 3. So our target should be at least 2B or 3. What does it mean? 2B means at least 50% of the cerebral blood flow, 50% of vascular territory, whether it's MCA, ACA, or PCA. Posterior artery, anterior artery, or metacerebral artery, the area that has been gone into ischemia, there should be at least 50% improvement in the blood flow. That should be our target, 2B. And 3 means there is a complete revascularization. In this case, there is a complete revascularization after mechanical thrombectomy plus IV thrombolysis. Now, regarding the cost of the treatment, is the main slide. It's very important here in our scenario, especially in Nepal, where most people cannot afford it. The procedures, the cost of treatment at our hospital will be the procedure charge plus cost of the IV tenant replace. We selected IV tenant replace because it's quite cheaper as compared to Altiplace. Altiplace, I think it will cost around 80,000. It will cost around approximately 60,000. So we choose IV tenant replace over IV Altiplace in our treatment plan and protocol. Plus the cost of logistic, it will be 7.5 lakh plus 60,000 plus procedure charge. if any patient comes with a stroke and we will do mechanical thrombectomy, the cost of the treatment will be 7.5 lakh plus 60,000 plus procedure charge. Procedure charge we have kept very low as compared to Kathmandu. I think it will be around 5 to 6 times less as compared to Kathmandu. Looking at the cost of the logistic and the people in our surrounding, we have reduced. We can't reduce the cost of logistic because we have to buy it. But we can reduce the cost of the treatment, cost of procedure charge because we can do it. We can do at our own after discussing with the board. Listen, if we can do revascularization with aspiration only technique, that's why I told in the beginning. We'll attempt 2 attempts of the aspiration technique. If that fails, then only we'll use a stent. Then it will reduce the price of the cost by 2.5 lakh. And if we can reuse the previous catheter, you can do that. You can reuse the previous catheter using a ETO. It's called ETO sterilization technique. We have already bought it at our center, and we are going to install it. With the help of that ETO sterilizer, we can reuse our catheter. In those cases, we can, for the price of the cost of the treatment will be further reduced. So why? The question is why? That's why I told you that it's quite costly, right? 2.5 lakhs, so much, around 8-9 lakh it will cost. Then is it justified to do this treatment here? The answer lies here. The patient will be functionally independent after mechanical thrombectomy. You just imagine a patient is a singer by profession. Patient has developed in fact in his language area. He can't sing. He will lose his career. He has to find a new job. If he can invest some amount of money, then he can protect his career. Similarly, like a teacher, imagine a farmer work in the field, he has hemiparesis, what will happen to him? His life is gone. That life is gone already, and some person should be there beside him, will drag him in the wheelchair, and along with him, another family will also feel a burden. So, if we can prevent malignant MC infarct, will be discussed by Dr. Subodh later on. Malignant MC infarct is a condition that is because the proximal MC artery occlusion that causes massive edema and that needs a decompressive craniotomy to protect life. So if patient goes into develop MC infarct and develops a decompressive craniotomy, then patient cost will be high. Patient has to stay for a long ICU stay. Patient has to be in the ventilator for a long time, 1 month, 2 months. And patient even have to go under cranioplasty. There will be 2 surgery, different surgery, and which will cost a lot more than IV thrombolysis and mechanical thrombectomy. You believe me this? It will cost around 15-20 lakhs overall. And despite that, the patient is not going to be functionally dependent. You spend 15 lakhs for all this. If you don't do mechanical thrombectomy, patient develop infarct. And you have to do a decompressive craniotomy, cranioplasty, ventilator, long ICU stay, and despite spending 15 to 20 lakhs to that patient, you cannot make that patient functionally dependent. Someone in the home, someone in the family has to take care of that patients. So, better to do it early. So I would like to illustrate few cases which we have done here. We haven't done any mechanical thrombectomy till date because we haven't got that patient, the patient that is eligible for mechanical thrombectomy because of delay in time, arrival in time. Either patient arrive delay, which doesn't fit into our criteria, or patient develops a distal part of the infarction, like M2 to M4 branch, where even IV thrombolysis is enough. We don't need to do a mechanical thrombectomy. So these are few cases. I will start with the first. This is our first cath lab procedure. It's case of ACOM aneurysm. It's a ruptured ACOM aneurysm, which we have done endovascular coil embolization. You can see the aneurysm here. This part is called aneurysm. The SCA part goes into the balloon-like dilatation and it ruptures and it causes a hemorrhagic stroke. In this, you can see a coil here. We have put a coil inside the sac. Now it will not rupture again. The cost, we can do this treatment even by clipping technique also. You have to open the skull, you have to detect the brain, you have to go, so much edema will be there, so much damage, brain will be damaged. This cost of the We did this surgery at the cost of 5 lakh, including OT charge, ICU stay, medicines, catheter, cath lab procedures, everything, 5 lakh, just a 5 lakh. And this is our post-op patient. She is okay, she was smiling, she went home, she is still good, fine. She came to OPD 2 weeks back, and we are happy with that. Next. Case. This is a case of Lagos area infarct. I'll tell you, this is a DWI. DWI says that I'm the ischemia. It tells that you can see the white part. It tells that the blood flow in this region is low. If you ask me, this region is called the language area, superior part of the left temporal lobe. Language area. If anything happened to this region, the patient cannot speak. And this is called a FLAIR image, where you can see a no hyperintensity. That means the patient has, this part of area is ischemia, but has not died yet. This patient came to our emergency, we evaluated it, we find out that is an infarct, then we did a imaging, so the imaging, CT angio, or we can call it MRI angio, I guess. Oh, we did imaging showed that the distal part of the MCA is blocked. This is not a criteria for mechanical thrombectomy, so we didn't go for it. We did a IV thrombolysis, and you can see the result of the IV thrombolysis in this patient. This is the pre-thrombolysis. He cannot speak. And you can see the post-thrombolysis effect where the patient came to our OPD and he was speaking so nicely to us. Imagine the patient was the singer and we could have done this treatment to him, or would happen to him. This is the external coiling we have done at our center. This is also cause of hemorrhagic stroke. It's not a ischemic stroke, but I am showing these cases because to show that even we have not got a case of mechanical thrombectomy, we can do these cases easily because we have done more complex procedure than mechanical thrombectomy. These procedures are quite difficult as compared to mechanical thrombectomy. This is aneurysm. We call it ICA PCOM aneurysms. It's a rupture. It's PCOM artery. This is ICA, we call it. Many of you may not be knowing this, but you should know that this part is dilated. This source of bleeding here. Next. In this case, we put a stent-assisted coiling because of wide neck and coil was literally migrated upward. You can see we put a coil here and we put a stent here. Again, this is stent, this is a coil. We have filled the sac with the coil and supported the coil with the stent because some part of the coil was going outside. This you can see, stent, beautiful picture, post coiling. After coiling, we did an angiogram that showed that there is a complete distal flow. You can see the good flow here, going past the aneurysm, but there is no filling here. That means this patient will not bleed again. The patient came to our OPD later on, and I did a CT angiogram. You can see this is a picture of the CT angiogram. This is a very good distal flow, and you can see that these are the aneurysms. There is no flow at all, and this is the stent. This case we have done, I think 1 month back. Patient was good. She came to our OPD. There is no any deficits. Next case. This is the case of MCA aneurysm. You can see aneurysm here. This is upper superior branch, this is inferior branch. If you see, you ask me, there is no flow at all. The commonest complication of the rupture aneurysm is the vasospasm. The same thing happened to this patient because of vasospasm. Most of the vessels shrink in size. Because of that, the blood flow will decrease heavily in the peripheral part of the brain. That's why you cannot see the flow at all. This is the post-procedure. You can see we gave an injection nimodipine. It's a drugs that dilate the vessels. We did that procedure using a cath lab. So cath lab is so important. Intravascular procedure is so important in these patients. We use a cath lab. We first dilate the vessels. We open all the vessels. After that, we put a coil here. You don't see the aneurysm anymore here. There is no aneurysm at all. In previous photo, there was aneurysm. The aneurysm has been obliterated. There is a good collateral flows. The patient is okay. We are happy. Next patient. And this case of was referred by Professor Gundi. Thank you, sir, to us for actually they planned this case. This patient came to their OPD and they planned surgery. And sir realized that it could be a vascular malformation. Hence he referred to us. And that patient we did a DSA. We did an external carotid artery DSA that showed a AVM fed by the middle is a maxillary artery, a branch of maxillary artery that it is feeding. You can play it. It's a AVM over the nose, and you can see the AVM over the nose. The plan of the treatment of this patient was to take a catheter here and to completely obliterate this AVM using a glue. And we have planned the patient for endovascular glue embolization followed by cosmetic surgery. But this patient didn't come back. I think, I don't know why, maybe the cost of the procedure was quite high for him. He didn't come back. This was the case. We have planned for embolization followed by cosmetic surgery by ENT department. But we couldn't do it because patient didn't follow up to us later on. Now, तल यो भइसकेको छ के सुरु त भइसक्यो बैक गर त Now, my last topic will be how to prevent recurrent ischemic stroke. The cause, I said in the beginning that the most common cause of stroke in the oldest people are the emboli that migrate from the carotid artery plaque. So, we call it a carotid artery stenosis. I mean, any asymptomatic patient with the carotid artery stenosis of more than 70% and a symptomatic patient with the carotid artery stenosis of more than 50% and not causing a disabling deficits. In those patients, we can do either open surgery, we call it the carotid endarterectomy. We open these regions and we remove the plaque and we switch out the vessels. And next technique is endovascular carotid artery stenting. This is the same technique. We do endovascular technique like mechanical thrombectomy, stent coiling or simple coiling or ABM embolizations. We can do it like that. Whether surgical treatment we perform or not, patient need to be on the independent and statin for a lifelong in this patient to prevent the recurrent stroke. If we do a carotid artery stenting in this patient, then we reduce the stroke risk by 10%. That means every 10 people in 100% will be prevented from the stroke each year. Each year, 10% will be prevented from the stroke if you do a carotid artery stenting in this patient. These are the criteria. So I advise everyone working in the periphery, working outside, if any patient present with the stroke, kindly do a carotid artery stenosis to rule out whether it is a significant obstruction or not. If it is there, we are here to help you. We are here to help the patient. Thank you. Next. This is a case. We can see a obstruction at 2 points, common carotid artery and the intercarotid artery. In this patient, there are the case of the symptomatic carotid artery stenosis. So we put a stent from here to this portion. And this patient should be on the antiplatelet for the lifelong. This is the our cath lab. I just put this image to show our cath lab, how we do it there. It's installed 6 months back, I guess. Next. This is our comprehensive stroke ICU. Where we will start, I think soon, from today onwards. Mind is everything. What do you think you become? Thank you for listening.
एक समय थियो जब स्ट्रोक आयो भने केही गर्न सकिदैन थियो भन्ने धारणा थियो र त डायग्नोसिसको सुविधा थियो र एडभान्स उपचारको फ्यामिलीले आफन्तलाई हेल्पलेस भएर हेर्ने बाहेक केही गर्न सक्दैनथ्यौँ तर आज परिस्थिति बदलिएका छ नाउ विथ एडभान्स Now with medical advancement like mechanical thrombectomy and IV thrombolysis, we have power to reverse the stroke, to give someone their life back, their movement back, their speech back. And we are proud to say that our hospital, ZeeNepal College of Medical Science, is going to launch the stroke unit soon after the session and provide such advanced services. Let's spread awareness, let's not wait, let's act fast, because now we have the technology, we have the expertise, and we have the will. तर सबै स्ट्रोकहरू अर्ली ट्रिटमेन्टबाट रिकभर हुँदैन. Some stroke becomes so severe, so massive that can also cause dangerous brain swelling. In such cases, surgery becomes only the hope. To help us understand this critical intervention, हामी आज आमन्त्रित गर्न चाहन्छौँ Dr. Subodh Gautam सरलाई, who will speak on the role of decompressive craniectomy.
नमस्कार सबैजनालाई. Thank you so much. हामीले बिरामीहरू भेट्छौँ. अहिलेसम्म जति पनि संसारभरि स्ट्रोकको बिरामी उपचार भइरहेको छ त्यो मध्येमा 10%ले मात्रै यो थ्रोम्बेक्टोमी थ्रोम्बोलाइसिस पाउनु भएको छ. यो यहाँको डाटा हैन, अमेरिकाको डाटा है त. सो 10% को डाटा पाइराख्नु भएको छ. हामीलाई भन्न धेरै सजिलो हुन्छ, तपाईलाई पक्षाघात भएछ, प्रेसरले हानेछ, यो दबाई खानुस्, थेरापी गर्नु, ठिक भएछ. तर एउटा 40 वर्षको मान्छेलाई जसको घरमा उसको परिवार, श्रीमती, बच्चापछि पालिरहेको थियो, त्यो मान्छेको हात खुट्टा नचल्दा कस्तो पीडा हुन्छ, सोसियली, फाइनेन्सियली, अनि कति गाह्रो हुन्छ भन्ने कुरा त्यो पेशेन्टको लेभलबाट उभिँदा मात्र थाहा हुन्छ. सो मैले आई एम गोइङ टु प्रेजेन्ट द टपिक द्याट इज डिलेड म्यानेजमेन्ट अफ इस्केमिक स्ट्रोक. भनेको अहिले हाल संसारभरि नै हामी नेपालमा स्पेसली जसरी स्ट्रोकको बिरामी म्यानेज गरिरहेका छौँ त्यही नै हो मेरो प्रेजेन्टेसन. तर म आजबाट जो हामी अब सञ्जीवनीमा एनजिएमसीमा जुन गर्दैछौँ, अब आउने दिनहरूमा जुन हामीले आशा गरेका छौँ है त, कुनै पनि बिरामीले चाहिँ मेरो प्रेजेन्टेसनमा भएको कुराहरू चाहिँ भोग्न नपरोस्. सबै बिरामीले स्ट्रोक भइसकेपछि डाक्टर निरजले भनेका कुराहरू, डाक्टर मनिषले, डाक्टर आशिकले भनेको कुराहरूबाटै उपचार पाएर अस्पतालमा आइसकेपछि एउटा राम्रो फङ्सनल लाइफ बिताउन सक्ने उपचारको अपेक्षा हामीले गरेका छौँ. र यो प्रेजेन्टेसनको मेन उद्देश्य पनि यहाँबाट तपाईँहरूको माझबाट जुन बिरामीहरू आउनुहुन्छ या पेरिफेरीमा जुन बिरामीहरू हुनुहुन्छ उहाँ चाहिँ त्यो हिसाबले आउनुहोस् भन्ने हाम्रो अपेक्षा छ. तर पनि भौगोलिक हिसाबले, फाइनेन्सियली हिसाबले रिफरल ढिलो हुँदा, डायग्नोसिस ढिलो हुँदा, सिम्टम ढिलो थाहा पाउँदाखेरि चाहिँ हामी अहिले पनि विवश छौँ. मोस्ट अफ द पेसेन्ट what we get is that they already have a delayed presentation. हामी 4.5 घण्टाको कुरा गर्दाखेरि हामी कहाँ आउने बिरामीहरू प्राय 18 घण्टा 16 घण्टा डिपेन्डिङ अपन द लाइक स्ट्रोकको कति ठुलो स्ट्रोक छ त्यो हिसाबले ढिलै पाउँछौँ. तर यो अवेरनेस प्रोग्रामले चाहिँ त्यसलाई छिटो होस् भन्ने हाम्रो धारणा छ. तैपनि हामी घरमा बिछना नहुँदा भुइँमा सुत्छौँ, भुइँ नहुँदा आगरमा सुत्छौँ, त्यस्तै कुरा हो. जति सकिन्छ जहाँबाट सकिन्छ बिरामीको ज्यान बचाउनका लागि उपचार हामीले लेभल वाइज हामीले डिफ्रेन्सिएट गरे हुन्छ. त्यो चाहिँ एउटा स्ट्रोक टिम मिलेपछि बल्ल हुन्छ. सबभन्दा पहिले चाहिँ एउटा स्ट्रोक टिमले चाहिँ अब बेसिकली प्राथमिक उपचारबाटै समाधान गर्न सक्यो भने सबभन्दा राम्रो थियो. भएन इन केस स्ट्रोक भइहाल्यो भनेपछि त्यसलाई हामीले कसरी समाधान गर्ने त? भइसकेको कुरालाई न्युट्रलाइज गर्न सक्नु पर्यो, बिस्तारै त्यसलाई घटाउन सक्नु पर्यो, या चाहिँ विथ टाइम त्यसलाई बढ्न नदिने उपायहरू के छन् त? त्यो बिरामीको भइसकेको डेफिसिट भन्दा अझै बढी नहोस् भन्नेको लागि के गर्न सकिन्छ? बेसिकली आई एम ट्राइङ टु फोकस अन दोज थिङ्स. सो आई लाइक टु स्टार्ट माई प्रेजेन्टेसन. सो डिलेज म्यानेजमेन्ट भनेको चाहिँ यदि द पेसेन्ट इज नट सुटेबल फर द आइभी थ्रोम्बोलाइसिस ओर इन्टरभेन्सनल थ्रोम्बेक्टोमी, कसैलाई चाहिँ थ्रोम्बोलाइसिस गर्ने पिरियडमा आउनु भएन या थ्रोम्बेक्टोमी गर्न मिल्दैन, त्यो पिरियड गइसक्यो भनेपछि त्यसपछिको फेजको लागि चाहिँ हामीले डिलेज म्यानेजमेन्ट भनिन्छ है त. स्ट्रोक भइसकेको छ त्यसलाई हामीले कसरी म्यानेज गर्न सकिन्छ? बिरामीले चाहिँ भइसकेको कुरा जे भइसकेपछि चाहिँ त्यसलाई एकदम बेस्ट आउटकम दिन के गर्न सकिन्छ त्यसमा म बोल्दैछु. अब इनिसियल एसेसमेन्ट धेरैजनाले भनिसक्नु भएको छ, त्यो मैले बारम्बार जानकारी दिनु पर्दैन. तर पनि लाइक एउटा पेसेन्टलाई नर्मल आइसियुमा राख्नु र एउटा न्युरो डेडिकेटेड स्ट्रोक आइसियुमा स्पेसली राख्दा धेरै फरक हुन्छ है त. एउटा सेम प्रकारको बिरामीहरू हेर्दाखेरि स्टाफहरूलाई, डक्टरहरूलाई सबैलाई कुन प्याटर्नले कुन प्लेटफर्मले बिरामी हेर्नुपर्छ भन्ने कुरा आइडिया हुन्छ र अरू बिरामीभन्दा फरक किसिमले चाहिँ होसहरू कम हुने, फरक किसिमले चाहिँ व्यवहारमा परिवर्तन भएर चाहिँ नयाँ सिम्टम देखिने आइडिया भएको हुनाले इन जेनरल सबै न्युरो भएको युनिटमा नै न्युरो आइसियुमा बिरामी राख्दाखेरि एकदम राम्रो हुन्छ है. त्यसमा हामीले अब भनिहाल्नु प्रिभियस स्पिकरहरूले वी हेभ टु चेक द बिपी रुटिनली. हाइपोग्लाइसिमिया एउटा इन्जुरी भइसक्यो, सेकेन्डरी इन्जुरी नहोस् भन्ने नै हाम्रो उद्देश्य हुनुपर्छ. जे भइसक्यो त्यो भइसक्यो, योभन्दा फर्दर नहोस् भन्ने नै हाम्रो उद्देश्य हुनुपर्छ. सो अब सबैलाई अब कति बिरामीहरूको अब आर्थिक अवस्था कमजोर हुन्छ, कतिको सिटी स्क्यानमा एमआरआईमा सानै स्ट्रोक हुन्छ, सबैलाई हामीले आइसियु राख्न पनि सक्दैनौँ, पैसा पनि सबैसँग हुँदैन। तर पनि अब कुनै डेफिनेट क्राइटेरिया त छन्। लाइक अब हामीले चाहिँ यतिमा एउटा आइसियुमा बस्ने अपरेसन गर्ने भन्ने कुरा एउटा रहरले हुँदैन, कसैलाई पनि एउटा कर बाध्यताले नै हुन्छ, सबैलाई, बिरामीलाई पनि हामीलाई पनि है त। सो अब बिरामीको अवस्था मोडरेट स्ट्रोक छ, अघि नै एनएचएस क्राइटेरिया दिइहाल्नु भयो। अल्टर मेन्टल स्टेटस, बिरामीको होस मानसिक अवस्था ठिक छैन, होस एकदम गुमेको छ र रेडियोलोजिकल सिटी एमआरआईमा अलिकति मोडरेट साइज इन्फ्याक्ट देखिरहेको छ, अलिक ठुलो छ, यो अझै बढ्न सक्ने सम्भावना भएको पेसेन्टहरूलाई पनि भर्ना गर्नु पर्यो। यहाँ चाहिँ सिटी स्क्यानमा एमआरआईमा हेर्दाखेरि सुरुमै एउटा मास इफेक्ट, एउटा सुजन, एउटा स्वेलिङ देखिसकेको छ भनेपछि यो बिरामीले पछि फर्दर गएर फेरि अवस्था बिग्रिन सक्छ भने त्यस्तो बिरामीलाई मोनिटरिङ गर्नको लागि हामी चाहिँ भर्ना गर्ने गर्छौँ। त्यसमा पनि स्पेसली अझै सिभिरिटीको आधारमा हामीले न्युरो आइसियु भनेर स्पेसली भर्ना गर्ने गर्छौँ। अब आइसियु केयरमा त्यही हो, न्युरो प्रोटेक्सन, बिरामीहरूलाई उठाउनु पर्ने कुराहरू हुन्छ 30 डिग्री। अहिलेको लागि चाहिँ बिपी, सुगर, अक्सिजन कन्ट्रोल हुने मेन इम्पोर्टेन्ट कुराहरू हुन् होइन। त्यसपछि गएर पहिले के भने त्यो बिरामीलाई चाहिँ न्युरोको बिरामीलाई एकदमै त्यो धेरै लाइटहरू दिनुहुन्न, अँध्यारो कोठामा राख्ने। अहिले के भन्छ सेमी लाइट, सेमी डार्क रुममा राख्ने, किनकि हामीले मोनिटर पनि त्यही हिसाबले गर्नुपर्ने हुन्छ। लाइटले एउटा फोटोफोबिया, मेन्टल इरिटेसन हुनाले सकभर एकदम उज्यालो लाइटमा राख्दाखेरि बिरामीले मानसिक सन्तुलन अझै बिग्रिने, अझै इरिटेट हुने सम्भावना भएको हुनाले हल्का सेमी लाइट रुममा राख्ने भन्छ है त। अब पर्फ्युजन प्रेसर, अघि नै हामीले बिपीको कुरा गरेको त्यही हो, पहिलेदेखि नै अब एउटा ठाउँ त नसा ब्लक भएर बन्द भइसक्यो, सुकिसक्यो, अरू ठाउँ पनि नहोस् भन्नेको लागि एउटा अप्टिमाइज बिपी चाहिँ हामीले मेन्टेन गरिरहेको हुन्छौँ। धेरै कम हुँदा पनि त्यसबाट फेरि नयाँ ठाउँमा स्ट्रोक हुनसक्छ, त्यो प्रिभेन्ट गर्न पनि हामीले आइसियुमा मोनिटरिङ गरिरहेको हुन्छौँ। र अब आएर कुरा आउँछ कि सबै बिरामी चाहिँ दबाईले मात्रै आइसियुमा भर्ना गरेर ठिक हुन्छ त स्ट्रोक बिरामी, या चाहिँ के सबै बिरामीलाई अपरेसनै गर्नुपर्ने हो त? होइन। इस्केमिक स्ट्रोक जुन कमन भनिन्छ त्यो मध्येमा लाइक 10%लाई मात्र अपरेसन गर्नुपर्छ। 90% अफ द इस्केमिक स्ट्रोक दे डु गुड विथ लाइक कन्जर्भेटिभ म्यानेजमेन्ट, रिहेबिलिटेसन केयर, थेरापी होइन, मेडिकल म्यानेजमेन्ट ठिक हुन्छ। तर त्यही मध्येको 10% बिरामीलाई चाहिँ बिस्तारै बढेर चाहिँ अपरेसन गर्नुपर्ने समस्या आउँछ, अपरेसन आउने सम्भावना हुन्छ। त्यसैले एउटा एन्सर म सबैलाई दिन चाहन्छु। कति बिरामीले सोध्नुहुन्छ, डाक्टर साहब मेरो बिरामी त त्यहाँ अनि अस्ति नै भर्ना हुनु भएको थियो, त बाहिरै ओपिडीमा आउनुभयो, जानुभयो, अर्कोले भन्नुहुन्छ म त वार्डमा भर्ना भए गएँ, बेकारमा पैसा ठग्दै हुनुहुन्छ। त्यो होइन। म तपाईँलाई एउटा इक्जाम्पल देखाउँछु। यहाँनिर हामीले जुन बिरामीलाई सानो स्ट्रोक भनेर मोनिटर गरेका थियौँ, त्यसपछि त्यो बिरामी अपरेसन गर्नुपर्ने अवस्था पुग्नु भएको छ। सो हामीले चाहिँ बिरामीको एउटा हामीले 100मा 79 जना बिरामी ठिक होलान्, तर हामीले उपचार गर्ने त्यही 1 जना बिरामी बचाउनु हो। त्यसको लागि हामी डक्टर भएको, हामी के अरे स्वास्थ्यकर्मी भएको, त्यस 1 जना बिरामीको ज्यान बाँच्छ कि भनेर हामी उपचार गर्दैछौँ है त। त्यही 1 जनाको लागि सायद राख्नु पनि हुनसक्छ है आइसियुमा। सो अब कसलाई कन्जर्भेटिभ गर्ने है? अब स्टेबल पेसेन्ट जो एकदम स्टेबल हुनुहुन्छ, जसको चाहिँ माथि टाउको प्रेसर एकदम बढेको देखिँदैन, होस् एउटा ठिकको रूपमा देखिन्छ, हामीले न्युरोसर्जनले, न्युरोलोजिस्टले हेर्दाखेरि चाहिँ क्लिनिकली उहाँहरूलाई हेर्दाखेरि चाहिँ उहाँलाई ठिकै छ वार्डमा राख्न मिल्छ भन्ने बिरामीहरू, या चाहिँ आइसियुमा राख्न मिल्छ भन्ने बिरामीहरू, या चाहिँ त्यो इन्फेक्सनको जुन प्रेसरले हानेको मस्तिष्क घातको ठाउँ छ त्यो अलिक सानो छ भनेपछि उहाँहरूलाई चाहिँ हामीले एउटा अब्जर्भेसन या चाहिँ कन्जर्भेटिभ म्यानेजमेन्टमा बढ्छ कि बढ्दैन 2-3 दिन हेरेर त्यसको आधारमा हामीले प्लान गर्न सकिन्छ फर्दर उहाँलाई कसरी अगाडि बढ्ने भनेर है त। तर त्यही मान्छे गएर अब एउटा इक्जाम्पल देखाउँदैछु मैले। उहाँको चाहिँ अब के छ, यहाँनिर सानो एक ठाउँ यति कालो भएको थियो है त, यो कालो भएको थियो, बिरामीले अलि जिब्रो देखाउँदै हुन्छ भने बुवा जिब्रो देखाउनु भयो। उहाँलाई हामीले चाहिँ सायद अब त्यति बेला उहाँको एमआरआई भएको थिएन, प्याची स्ट्रोक अलिअलि माथिपट्टि छ, हामी डाउटमा चाहिँ हामीले उहाँलाई भर्ना गरेको 8-9 घन्टापछि म्याक्सिमम मेडिकल म्यानेजमेन्ट गर्दा पनि 8-9 घन्टापछि उहाँको अवस्था बिस्तारै कम हुँदै गयो है त, होस कम हुँदै गयो, रेस्पोन्स कम हुँदै गयो। त्यसपछि फेरि हामीले के गर्यौँ, अब उहाँलाई हामीलाई क्लिनिकली डाउट लागेपछि त्यो बिरामीको हामीले अनि फेरि सिटी स्क्यान गऱ्यौँ, त्यसमा फेरि आउँछौँ है त के भयो भन्नु उहाँको लागि है त। सो कन्जर्भेटिभ म्यानेजमेन्ट गर्दा हामीले के गर्यो त बिरामीलाई भन्दाखेरि हामीले अक्सिजन, हाइड्रेसन, बिपीका कुराहरू भयो, न्युट्रिसन होइन, अनि बिपीको म्यानेजमेन्ट कुराहरू भयो, एन्टिप्लाटिक थेरापीहरू कुरा भयो, स्ट्याटिनहरू जुनको बारेमा सायद अगाडि हाम्रो सरले भनिसक्नु भएको छ, डिबिटी प्रोफाइलेक्सिस। एउटा बिरामी अस्पतालमा सुतिरहँदाखेरि तपाईँ नर्मल्ली नै हामी नै 2-3 दिन घरमा सुतौँ, हामीलाई निमोनिया सुरु हुन्छ भनेपछि जो बिरामीले आफ्नो जिउ नै अङ्ग चलाउन सक्नु भएको छैन उहाँलाई निमोनिया हुने चान्सेसहरू, खुट्टाको नसा ब्लकेज हुने चान्सहरू, डाक्टर कृष्णले भने जस्तै मुटुको रोग फेरि बढ्ने सम्भावना बढी हुन्छ। सो त्यसको लागि चाहिँ अर्ली नै हामीले केयर गर्नुपर्ने हुन्छ। अर्ली रिहेबिलिटेसन केयर आइसियुमा छातीको लागि स्पेसली, किन मोस्ट कमन नै हामीले सुतिरहँदाखेरि भन्छ नि जमेको पानीमा किरा पर्छ भने जस्तै सुतिरहँदाखेरि छातीको इन्फेक्सन भएर मान्छेलाई निमोनिया हुन्छ। त्यो निमोनिया पछि होला, त्यो प्रिभेन्सन गर्नको लागि हामी पहिलेदेखि लाग्नुपर्ने हुन्छ। आइसियुमा हामीले यही गर्ने हो है त। ओके, अब गएर के हुन्छ भन्दाखेरि अब मैले अघि भने जस्तै 100 जनामा 10 जनालाई चाहिँ अपरेसन गर्नुपर्छ। त्यो 10 जनामा चाहिँ एउटा क्राइटेरिया हो जसलाई भनिन्छ म्यालिग्नेन्ट एमसी इन्फ्राक्सन, जुन हामीले डक्टर दिदीले भर्खर कुरा गर्दै हुन्थ्यो। यदि त्यही अघिको पेसेन्टलाई हामीले टाइममै इन्टरभेन्सन गर्न पाएको भए यो अवस्थामा पुग्नु थिएन। र यो अवस्थामा पुग्नुभयो, त्यसपछि के भयो, यो पुरै एरिया कालो भइसक्यो। यो एमआरआईको फाइन्डिङमा देखिरहेको छ। अब यसले गर्दाखेरि के हुन्छ, हाम्रो मस्तिष्क र मेरुदण्डको मेन ब्रेन स्टेमलाई थिच्छ, त्यसपछि गएर हाम्रो होस कम हुन्छ, आँखाको नानी हराउँछ। त्यो हुँदाखेरि कतिपय बिरामीहरू चाहिँ अब अर्ली थाहा हुने त आउनुहुन्छ, कतिपय बिरामीहरूलाई के हुन्छ भन्दाखेरि घरमा बस्दा बस्दै अब कोही आउन नसकेर होइन ठिक भइहाल्ला, गाउँमै अब आर्थिक अवस्था कमजोर छ, भूगोल हाम्रो अप्ठ्यारो छ, त्यही भएर कति बिरामी ढिलो पनि आउँछ। यो एमसी स्ट्रोक ढिलो हुँदाखेरि मान्छेहरू चाहिँ आउँदाखेरि अल्टर सेन्सोरियम होस पुरै गुम भइसकेको, झट्काहरू छारे भएर आउने, टाउको प्रेसर बढेर आउने, यहाँ चाहिँ गएर एकदम डिले डायग्नोसिस हुने कुराहरू हाम्रोमा आइराख्नुहुन्छ है त। अब त्यो भइसकेपछि सेम पेसेन्टलाई म देखाउँदैछु, त्यसपछि के भयो, 8-9 घन्टापछि रिप्रेजेन्टेसन गर्दाखेरि हामीले हेरेछौँ यो कालो भाग चाहिँ पुरै आदि गरेर यहाँ बढिसकेको छ। अहिले बिरामीले उठाउँदाखेरि बिरामीले जिब्रो देखाउन्न, चिमोड्दाखेरि मुस्किलले त्यो ठाउँमा मेरो हात लग्नुहुन्छ भनेको अब जिसिएस जुन हामीले क्राइटेरिया हेर्छौँ त्यो कम भइसकेको छ भनेको अब आएर एउटा इन्डिकेसन भइसक्यो उहाँको, के को अपरेसन गर्नुपर्ने। र उहाँलाई हामीले हिजो नै घर पठाएको भए के हुन्थ्यो त, उहाँ बाँच्नु थिएन। सो त्यही एकजना बिरामी बचाउनको लागि आइसियुमा मोनिटर गर्नुपर्ने हुन्छ। सानै भए पनि कहिलेकाहीँ एएफको बिरामी, कार्डियोको बिरामीहरू त रिस्ट्रोक भइरहेको हुन्छ, आइसियुमा जाँदाखेरि बिपी टाकिकार्डियाहरू भएर रिस्ट्रोक भइरहेको हुन्छ। सो त्यो चेन्जेस हेर्नको लागि पनि आइसियुमै मोनिटर गर्नुपर्ने हुन्छ। त्यसपछि हामीले उहाँलाई अपरेसन गऱ्यौँ। अपरेसन गर्ने क्राइटेरिया के छ इन जेनरल सबैको लागि, एकदम 50% भन्दा ठुलो इन्फ्राक्सन एमसी इन्फ्राक्सन छ भने उहाँलाई अपरेसन गर्नुपर्ने हुन्छ। मिडलाइन सिफ्ट 5 mm भन्दा बढी छ भने अपरेसन गर्नुपर्ने हुन्छ। सो वर्सनिङ कन्सियसनेस, if the disease drops, then also we'll have to go for operative intervention. And if there is sign of uncle herniation that are characterized by thornal palsy and dilated pupil, and ideal timing के भन्छ भन्दाखेरि एमसी इन्फ्राक्सन तपाईँहरूले सिटी एमआरआईमा देख्नुहुन्छ भनेपछि पहिले के हुन्थ्यो, अब थ्रोम्बोलाइसिसको कुरा हुँदाखेरि मैले यो जानकारी सबैलाई दिन खोजेँ। सो थ्रोम्बोलाइसिस गरेका मध्ये पनि टाइममा गर्दा पनि 9% अफ द पेसेन्टलाई फेरि अपरेसन गर्नुपर्ने चान्सेस हुन्छ। फेलियर अफ द थ्रोम्बोलाइसिस कहिलेकाहीँ हुन्छ, तर हाम्रो उद्देश्य भनेको 9%लाई होइन, हामी चाहिँ 91%मा पढ्न चाहन्छौँ, त्यही भएर थ्रोम्बोलाइसिस गर्नुपर्छ। सो 9% भएको बिरामीलाई पनि अपरेसन गर्नुपर्ने चान्सेस छ। अब आएर हाम्रो अपरेसनको गोल के त, अपरेसनको गोल भनेको एकदमै तत्कालै हामीले हातखुट्टा चल्ला, बिरामी हिँडेर जानला भन्ने होइन, एउटा लाइफ सेभिङ प्रोसिजर मात्र गर्न खोजेको, बिरामीको ज्यान बचाउन खोजेको। पहिले गएर ज्यान बचाउनु पर्यो, ज्यान बचिसकेपछि अर्को फेजमा गएर फेरि हामी रिहेबिलिटेसन, चेस्ट केयरहरू, अरू मेडिकल म्यानेजमेन्ट गरेर फेरि एउटा नयाँ जीवन दिन सकिन्छ कि भन्ने प्रयासमा हामीले गर्दैछौँ। तर त्यो प्रयास मैले भनिहालेँ कहिलेकाहीँ धेरै ढिलो पनि हुन्छ। त्यो बिरामीको उमेर अनुसार, साइज अफ द इन्फेक्सन अनुसार, आएको टाइम अनुसार, अपरेसन गरेको टेक्निक अनुसार फरक पर्ने हुनाले 30 वर्षको मान्छेमा अपरेसन गर्नु र 70 वर्षको मान्छेमा अपरेसन गर्नु त्यही रिजल्ट नै फरक आउँछ है त। सो पहिले के भनिन्थ्यो भन्दाखेरि एमसी इन्फेक्सन हुँदाखेरि चाहिँ होइन, जब चाहिँ बिरामीको होस कम हुन्छ अनि बल्ल अपरेसन गर्ने भन्ने कुरा आयो। त्यसपछि 2007मा के कुरा आयो भन्दाखेरि होइन, छिटै गरेको फाइदा हुन्छ भन्ने कुरा आयो। 2009मा चाहिँ कन्फर्मेटरी एउटा ह्यामलेट ट्रायल भन्नेले के भनेपछि सबभन्दा राम्रो रिजल्ट चाहिँ 48 घन्टाभित्र गर्न सकेपछि मात्रै हुन्छ भन्ने कुरा आयो। त्यसपछि गएर 2016मा पहिले चाहिँ 60 वर्षभन्दा माथिको मान्छेलाई सकुन अपरेसन गरेर फाइदा छैन भन्ने जुन कुरा थियो, अहिले आएर त्यो उमेरको मान्छेलाई पनि अपरेसन गर्दाखेरि फाइदा हुन्छ भन्ने कुरा आइरहेको छ र हामीले त्यो गरिरहेको पनि छौँ। अब फाइदा के हुन्छ त भन्दाखेरि त्यसले मृत्युदर 50% कम गराउँछ अपरेसन गरेर। सो 10 जनामा 5 जना हामीले लाइफ बचाउन सक्यौँ। फङ्सनल आउटकम जुन एउटा मरिसकेको टिस्यु थियो त्यहाँ पनि एउटा हामीले चाहिँ पछि गएर त्यो फङ्सनिङ गराउन सकिन्छ। अनि मेन उद्देश्य भनेको हाम्रो टाउको प्रेसर घटाउने, आइसिबी घटाउने मेन उद्देश्य हो। हामीले त्यसमा अब बोन निकालेर ल्याक्स ड्युरोप्लास्टिक गरिदिनु पनि हुन्छ। त्यहाँ पनि कुरा आउँछ कत्रो साइज, यहाँ हेर्न सकिन्छ यो अपरेसनमा यो धेरै सानो बोन फ्ल्याग निकालिएको छ, त्यही भएर आइसिबी अझै कन्ट्रोल नभएर यहाँबाट ब्रेन बाहिर आइरहेको छ। सो तपाईँको लाइक टेक्निक एन्ड साइज अफ द फ्ल्याग इज भेरी लाइक डिटरमाइनिङ रिगार्डिङ द प्रोग्नोसिस अफ द पेसेन्ट है त। यु हेभ टु बी भेरी मच स्योर द्याट वाट एभर यु हेभ डन, लाइक हामीले जे गरिरहेको हुन्छौँ त्यो चाहिँ इनफ छ पेसेन्टको लागि आइसिबी डिक्रिज गर्नको लागि। सो इफ यु गो टु द नेक्स्ट पिक्चर, दिस इज द पेसेन्ट विच वी अपरेटेड, लाइक उहाँको यो बोन फ्ल्याग ठुलो छ। अहिले आएर फेरि उहाँको पेसेन्ट बारीसँग उहाँ चाहिँ लकिली सबै गरेको के सक्सेस हुन्छ भन्ने हुँदैन, तर हाम्रो उद्देश्य चाहिँ सगैर बिरामीलाई एउटा नयाँ जीवन दिउँ भन्ने नै हुनुपर्छ। सबै सक्सेस होला नहोला तर बिरामी ज्यान बचाउन पुरै प्रयास गर्ने कि नगर्ने भन्ने कुरा मात्रै हो। अब आएर त्यसपछिको फेज भनेको बिरामीलाई एउटा हामीले भनिहाल्यौँ चेस्ट केयर गर्छौँ, अरू रिहेबिलिटेसन केयर गर्छौँ, डिबिटी खुट्टामा नखा जमल्स भनेर एक्सर्साइज गर्छौँ। त्यसको लागि एउटा बिरामीलाई हेर्नुहोस्, एउटा स्ट्रोक भइसक्यो बिरामीलाई 3-4 जना उठाउन मात्र लाग्छ भनेपछि हिँड आउन वर्काइ फर्काइ गर्न धेरै गाह्रो कुरा हो। न्युरो आइसियुमा पेसेन्टलाई म्यानेज गर्नु भनेको झन् बिरामीको होस नहुँदाखेरि त हामीले कहिलेकाहीँ त स्वास्थ्य कर्मी भन्नुहुन्छ कहिलेकाहीँ बिरामीले गाली गर्नुभयो, बिरामीले गाली गरे होइन बिरामीको रोगले गाली गरेको, बिचरा बिरामीले थाहा नै छैन बिरामीलाई के बोल्ला छ भनेर। तर हामी त स्वास्थ्यको हामीले त्यो कुरा बुझ्नुपर्छ है। सो अब त्यसपछिको फेज भनेको चाहिँ हामीले अब सबै कुरा ठिक रहेमा त्यो बोललाई फेरि हामीले 6 हप्तादेखि 12 हप्ताको ट्रायल अनुसार फेरि ब्याक हालिदिन्छौँ। सो टेक होम मेसेज के हो भन्दाखेरि मैले यो कुरा जति भने पनि आजको हाम्रो उद्देश्य भनेको चाहिँ सकभर कुनै पनि बिरामीलाई मैले भनेका कुरा मध्येमा केही पनि पर नपरोस्, सकभर अगाडिको प्रेजेन्टरले जुन थर्मोलाइसिस थर्मोमेटरमा जुन फोकस गर्नुभएको छ त्यो उपचारबाटै ठिक बनाएर हिँडाएर घर पठाउन सकियोस् भन्ने हाम्रो उद्देश्य सबैको हुनुपर्छ। र इन केस त्यो टाइममा नआएको खण्डमा मात्रै रिभास्कुलाइजेसन चाहिँ प्राइमेरी गोल हुनुपर्छ। त्यसपछि गएर डोन्ट मिस द विन्डो, विन्डो पिरियड जुन कुरा भयो 4.5 आवर अनि लास्ट भेसाक्लुजनमा 24 आवर, त्यसलाई चाहिँ सकभर त्यो विन्डो पिरियडमा कुनै सबै बिरामीलाई पार्न सकियोस् भन्ने हाम्रो चाहना हुनुपर्छ। र इन केस भएन भने जुन कन्सिक्वेन्सेस छ त्यसलाई पनि बेस्ट एउटा ट्रिटमेन्ट दिने हाम्रो जो उद्देश्य हुनुपर्छ। र डिकम्प्रेसिभ क्रानिक्टोमी ठुलो इन्फेक्सन एमसिएमा चाहिँ अहिले पनि लाइफ सेभिङ रोल छ, 100 मा 50 जनाको ज्यान बचाउन सकिन्छ। र टाइमली डिसिजन मेकिङ इज भेरी क्रुसियल। एउटा सानो एक्जाम्पल दिन्छु, एकजना बिरामीलाई भने अनि हिजो राति नै भएको तपाईँको हात कमजोर भएर चाहिँ किन नआउनु भएको त भन्दाखेरि होइन सरी लेडिजहरू बुढीले भन्नुभयो अरे हल्का कमजोर भयो भने बुढले के भन्नुभएछ हिजो राति अलिकति त्यो मोही खानु भएको थियो त्यसले गर्दा होला भन्नुभएछ, अलिकति बढेछ होइन तकिया बाङ्गो राख्नु भएको थियो त्यो भएर होला हात चलाउनु भएछ, एकछिनपछि अलि अगाडि जानुभएछ त्यहाँ गएर फेरि चाहिँ तपाईँको होइन बिपी बढेको बिपीको दबाई एम्ब्रोड दिएर पठाउनु भएछ, अझै बढ्दै गएछ। त्यसपछि बल्ल उहाँले चाहिँ सम्झिनु भएछ कि एम्बुलेन्सलाई फोन गर्ने, एम्बुलेन्सले पनि कहाँ पठाउने एउटा असल जानुभएछ त्यहाँ सिटी स्क्यान थिएन, फेरि अर्को असल जानुभयो सिटी स्क्यान भयो, त्यहाँ सिटी स्क्यान भएपछि यहाँ हुँदैन नेपालमा जानुपर्छ भनेर बल्ल हामी कहाँ पुग्नु भएको थियो। सो हाम्रो उद्देश्य भनेको यो सब टाइम डिलेलाई बी फास्ट जुन अघि नै आसिम सरले भन्नुभयो बी फास्ट पत्ता लगाउने बित्तिकै एउटा अब चेन्ज इज अ भेरी स्लो प्रोसेस है। यो हामीले अहिले भन्न साथुका दु भोलिबाट बिरामी पर्छबाट बिरामी यो वर्षौँ लाग्ने कुराहरू हुन्, बिस्तारै होला तर सुरु आजबाट हामी गर्दैछौँ है त। सो हाम्रो मेन उद्देश्य त्यही नै हुनुपर्छ। डिले इन आइदर रिभास्कुलाइजेसन और क्रानिक्टोमी क्यान बी फ्याटल। स्ट्रोक प्रोटोकल्स मस्ट प्रायोरिटाइज बोथ ऱ्यापिड डिफर्ब्युलेसन एन्ड अर्ली रिकग्निसन अफ दि सर्जिकल क्यान्डिडेट्स। सो यति भन्दै स्ट्रोकको अवस्थाबाट जहाँ पुगिन्छ ग्रो थ्रु वाट वी गो थ्रु, जे अवस्थामा छ त्यहाँबाट पनि ग्रो गर्ने प्रयास गर्नुपर्छ। यो सबै बिरामीको लागि हाम्रो मेसेज हुनुपर्छ। थ्याङ्क यू सो मच, इन्जोय योर इभिनिङ।
Thank you, Dr. Subodh Gautam sir, for your excellent presentation. Today marks not just a gathering, but a beginning of something new and exciting, an initiative that will leave a lasting impact. Stepping forward, now I have the honor of inviting upon the stage Dr. Suresh Kumar Kanodia sir, Dr. Muhyiddin Kidwai sir, for inaugurating Comprehensive Stroke Center at Sanjeevani College of Medical Science and Primary Stroke Center at ZeeNepal Medical College, Kohalpur. I would also like to invite Dr. Ritesh Kanodia sir, Dr. Kedar Agrawal, Dr. Roman Kidwai sir, Dr. Nirajan Subedi,
I'm very happy today. Dr. Manish, Dr. Neeraj and Dr. I'm very happy today. Our dedicated neurosurgeons, Dr. Manish, Dr. Neeraj and Dr. Subodh, who not only excel in the operating room but also have played a key role in making this program a reality. Thank you. Dr. Suresh Kumar Kanodia, CEO of ZeeNepal College of Medical Science, for giving his closing remarks. Please give him a round of applause.
Good evening, everyone. Respected Dr. Kanodia sir, Dr. N. Kidwai, Santosh BN sir, Dr. Kedar, Dr. Niranjan, Dr. Subhash, distinguished guests, dear colleagues and friends from various media houses. It is with great pride and gratitude that I stand before you today at the inauguration of our Comprehensive Stroke Center and Primary Stroke Center at Kohalpur. I'm also proud to announce that this is just the first step that Sanjeevani College of Medical Sciences is taking in developing a dedicated neuro center as the center of excellence for neurological and neurosurgical sciences. First of its kind in the entire West after Kathmandu, which will also incorporate neurology, endovascular surgery, neurorehabilitation with physiotherapy and nutritionist, neuroradiology and neuropathology. This is a significant milestone, not just for our institution, but for the entire region. I would like to sincerely thank all the distinguished guests, respected faculty members, speakers, health professionals and well-wishers for being part of this important event. The establishment of this event marks a new chapter in providing affordable, timely and advanced care to all our community. The CME reflects our shared commitment and continuous learning and improved patient outcomes. A special thank you to everyone who worked tirelessly behind the scenes, the administrative team, medical staff, nurses, medical officer, support staff, and various media houses. Your dedication and teamwork have made this vision a reality. Lastly, I would like to all of you to kindly raise a big round of applause for our entire neurosurgery team, Dr. Manish, Dr. Neeraj, and Dr. Subodh, for taking up this initiative and making this milestone a reality. Lastly, I would like to thank our board of directors for supporting our vision and really pushing us to deliver more to the public. Together, let us move towards strengthening stroke care and saving lives in Nepalganj and beyond. Thank you.
Thank you, sir. Now I would like to invite on stage Mr. Dr. Kedar Agarwal, promoter of NGMC, for a few words.
CT scan internal capsule on left side had very big hemorrhage. After seeing the CT scan report, she asked, "Where is the patient?" I indicated just the sitting my father. She was surprised that with this big hemorrhage, how he is so comfortable sitting. She examined, she prescribed some medicines. She asked me to consult Dr. Chabda, neurosurgeon, that he might do some surgery if needed. I went to Dr. Chabda in Sanjay Gandhi Institute just with the CT scan. He saw the CT scan and just indicated me, said me that take him home, don't try any funny things, just maintain blood pressure and do physiotherapy. And he survived for 18 years after that, without any bed sore, with good brain functions. Later on, as he was having right-sided hemiplegia, he adopted writing with left hand. He used to write letters to family members. So sometimes, even in that time, CT scan was very new one. We didn't have so much facilities, but now we have here in Nepal so much facilities that we are starting neuro centers with surgical facilities and things. I feel very proud of the things, but with what I had experience with my father, I feel that simple sympathy and care is also too much important, more than so many treatments. Thank you very much. Nothing too much.
Thank you, sir. Now moving forward, as a gesture of our heartfelt appreciation, we'd like to present a token of love to our distinguished guests.
Medical Superintendent of Bhedi Hospital, Dr. Niranjan Subedi. Medical Superintendent of Bardia Hospital, Dr. Subhash Pandey. President of Patrakar Mahasangh, Mr. Navin Giri.